Happy Sunday to all. Myself, I'm Dr. Deep Raja, will be the program coordinator for this particular session, this particular meeting today. Um, from the Indian Heart Rhythm Society, we are conducting DM DNB cardiology teaching programs. It falls on the first or the second Sunday of every month. This is an online meeting program where we will be discussing relevant topics related to cardiac electrophysiology. And this will be dealt with by cardiac electrophysiologists, reputed doctors from our own country. And We will be interacting with them directly, and you will have an opportunity to ask them and clarify all your doubts regarding cardiac electrophysiology. So it will fall on the first or the second Sunday of every month. For this particular meeting, because we understand the exams are around the corner, both the DM and the DNB exams, the theory exams, I think have started for the DNB, and the DM students is about to start. I thought, and we, myself and Deb Berra, have initiated this particular discussion on exam-related questions. We have 8 questions or 8 topics that will be discussed today. We have divided it into 2 sessions. The first session will be moderated by Dr. Deb Berra from Kolkata and Dr. Saurabh Deshpande from Mumbai. And then they will be introducing the speakers, one topic after the other. And this will go on for about an hour. And then we will have move to the next session, the session 2 of the exam relevant topics. So I will now hand it over to Dr. Deb and Dr. Saurabh to take the first session forward.
Yeah, good morning, everyone. So I think Deep has worked very hard to put together all very relevant topics without much delay. Saurav, can you introduce the first speaker? And I think we have a lot of attendees, and that will be very useful as far as exam is concerned, as well as practically and clinically as well. Saurav, it's up to you, and please introduce the speakers. Saurav, you are not muted. You are not muted. You are still muted. Yeah. Now we can hear you. Yeah.
Sorry. Yeah. Thank you everyone for joining. Thank you, Dr. Prera, Dr. Deep Raja for this particular meeting. Yeah, as has been told before, the topics are very relevant to the exam going students. So without wasting much time, I would like to invite Dr. Parag Barwad to present his approach to narrow complex tachycardia. Over to you, Dr. Barwad.
Thank you, Saurabh. And I'll be sharing my slides. So I hope the slides are visible, and I'm going on the presentation mode. Okay. That's the beginning of my presentation. I hope I'm clearly audible.
Yes.
My slides are visible. Okay. So thank you, Deba. Thank you, Deep. And as it's a DM DNB teaching program, I've kept it absolutely simple, clean, clear, no ambiguities, and it's a succinct presentation. Okay. So first of all, I would like to declare that this presentation has been actually made out of a publication done by Dr. Nitish Padwar. And this is the reference for that publication. So anybody from the students who want to have a reference and want to read the full article on that, it's very easily available online, free, and they can go through and read the article. You'll have much more information than what I am presenting. Okay. So narrow complex tachycardia by definition is any cardiac rhythm which is more than 100 beats per minute and the QRS duration is less than 120 milliseconds. The usual manifestations are very classical. Everybody knows about it. It's like persistent palpitations, breathing disturbances. Sometimes they can have exercise intolerance, lightheadedness, and may also experience chest pain. Usually the narrow QRS tachycardias are innocuous, but sometimes 20% of these patients can present with syncope, may experience hypotension, rarely can have heart failure, and up to even 2% of these patients can have a non-lethal cardiac arrest, but it's a non-lethal cardiac arrest, so don't have to worry about it. The 3 basic mechanisms for a narrow complex tachycardia is enhanced automaticity, a triggered activity, or a re-entry, and the most common amongst it is a re-entry. This is a jumbled up slide, but I'll try to very clearly simplify the slide, that how should you actually try to classify the narrow complex tachycardia. So there are 4 steps of classifying the narrow complex tachycardia, and there are so many classifications available that anybody can get confused, but I have tried to simplify it. So first step is whether the narrow complex tachycardia is a regular tachycardia or an irregular tachycardia. And what do you mean by that? If the RR variability is more than 20 milliseconds, it is considered to be irregular tachycardia. And there are very 5 classical differential diagnoses to that. The most common being the atrial fibrillation, where the heart rate is irregular, and then atrial flutter, which has got a variable AV block. Third is a multifocal atrial tachycardia, wherein you have multiple foci having multiple PR intervals, and that is why there is a variability in the RR interval. Then atrial bigeminies or trigeminies means like every second or a third beat is an atrial premature beat, which has got a different way of AV conduction, leading to a variable RR interval. Then there is a very rare variety of tachycardia called as dual AV nodal non-reentrant tachycardia. For that to understand, I have a separate slide for that. I'll get back to that. So first of all, you need to differentiate between regular RR and an irregular RR. For irregular RR, there are 5 differential diagnoses. When it comes to regular RR interval, you can say that the second step is whether there is 1:1 AV conduction and or else there are more A's than V's. If there are more A's than V's, then the differential diagnosis is either it is atrial tachycardia or an atrial flutter, which is conducting to the ventricle with a fixed AV block or a variable AV blocks. So that is one way of doing it. If there is a regular 1:1 AV conduction, then you can differentiate the tachycardia based upon one important concept is like RP interval. What is an RP interval? RP interval is the time duration between the end of the R wave to the next R wave is the RR interval. If you divide that RR interval into 2 halves, if the retrograde P wave or the P wave, not only retrograde, if the P wave falls in the first half, it is considered to be a short RP tachycardia like this. And if it falls into the second half, it is usually called as a long RP tachycardia. So if it is a short RP tachycardia, most common differential diagnosis is typical AVNRT, orthotomic AVRT, junctional ectopic tachycardia with retrograde A, or else atrial tachycardia with one first degree AV block. What do we mean by first degree AV block? Means that this is a short RP tachycardia because the P wave is just after the R wave, but the PR interval is so prolonged that this P is actually conducting to this R. So a short RP tachycardia can be because of atrial tachycardia with a long PR interval. When it comes to long RP tachycardia, what are the differential diagnoses? It can be atypical AVNRT, means that the antegrade limb is relatively faster than the retrograde limb, or else it can be atrial tachycardia, PJRT, and sinus tachycardia. These are long RP tachycardias. There are other ways of also looking into the mechanism of narrow complex tachycardia is by knowing the P wave morphology. We all know that the normal P wave morphology, the P wave is upright in 1, 2, 3 AVL and negative in AVR. And then depending upon the abnormalities of the P wave, we can actually make a diagnosis of either a atrial tachycardia, flutter, or a retrograde P wave. There is another very important publication which was done way back in 1997 in JACC, where they have actually tried to differentiate all narrow complex tachycardia based on only the retrograde P wave. This is a very jumbled up slide, but for the sake of kids or for the sake of students, I'm actually putting this so that they can go back and refer to this if they want to make a diagnosis of narrow complex tachycardia just on the basis of the retrograde P wave. It's a very good thing because when I was a student of Dr. Yash Lokhandwala and when he used to see a narrow complex tachycardia and make a diagnosis of a left lateral pathway, I'm saying this is an orthotomic AVRT. Why is he making a diagnosis of left lateral pathway when there's a narrow complex tachycardia and he doesn't have a baseline sinus rhythm ECG? I used to see that he used to see actually the retrograde P waves and the way the atria is being depolarized retrogradely and make a diagnosis of left lateral pathway. So this is the pictorial diagram of how all sorts of tachycardias happen. I'll go into each and every one slowly. But first of all, let me show you that if there is an AVNRT, which is a micro re-entry within the node, antegrade conduction is happening through the His-Purkinje system. And the atria is also depolarized retrogradely from the nodal area. So atria and ventricle are getting depolarized parallelly, simultaneously, and that is why it is called as a A on B tachycardia. Second variety is atrial tachycardia. There is a focus which is happening, and then it is going through the node. The ventricle is getting activated through the His-Purkinje system, narrow complex tachycardia. Atrial fibrillation, multiple foci, multiple circuits happening in the atria. Antegrade conduction to the ventricle is happening through the node, and it's a narrow complex tachycardia. AVRT. What this is shown is an orthodromic AVRT, means that the antegrade conduction to the ventricle is happening through the His-Purkinje system, and the atria is getting retrogradely activated from the pathway. As the pathway is not conducting antegradely, the ventricle is concentrically activated. It's a narrow complex tachycardia. If the sequence of activation goes on the reverse side, means like the ventricle is activated antegradely and the node is getting the node is getting depolarized retrogradely, you will have a very wide complex tachycardia, which is not my topic of discussion. So that is why I'm not going into antidromic AVRT. This is orthodromic AVRT. Coming to a flutter. Flutter can be typical and atypical. I'll go into minor details of that in some period of time. And there is a circuit going on in the atria. The circuit may be there in the right atrium. It may be there in the left atrium. The circuit goes on and the atria is getting depolarized at a particular rate, maybe 250, maybe 300, maybe 350. And a particular number of beats at a fixed interval or an intermittent way would be conducting through the node into the ventricle, leading to a fixed block or a variable block. Then comes a multifocal atrial tachycardia, where we have more than two foci, usually seen in patients of COPD or pulmonary diseases where the RA and RVs get significantly dilated. Each focus will have a variable PR interval, leading to a variable RR interval also. And there are more than two morphologies of P waves, and then only we call it as multifocal atrial tachycardia. Coming to the most common variety of supraventricular tachycardia or a narrow complex tachycardia is AVNRT. It's a micro reentry within the AV node where we have two varieties of pathways. One is considered to be a slow pathway, one is considered to be a fast pathway. There are two variants of AVNRTs also, depending upon how the conduction is happening across the node. If the antegrade conduction is happening through a faster pathway and the retrograde conduction is through a slower pathway, it is called as a typical AVNRT. So this is a pictorial diagram. This is the slow pathway. This is the fast pathway. Normally, when a normal individual conducts without tachycardia, the antegrade conduction happens through the fast pathway, this orange one. And there is a nice PR interval, which can be up to 120, 180, 160, depending upon how fast is the conduction across the pathway. And this is the PR interval. But what happens if there is an APC and patient is having both the slow and fast pathway? And see this is an APC which conducts antegradely through the slow pathway, giving rise to a longer PR interval. When this conducts antegradely and the conduction goes to the His-Purkinje system, in the meantime, this retrograde fast pathway is now able to conduct retrogradely towards the atria, giving rise to this QRS followed by this rapid A wave, which is at the terminal part of the QRS, giving like a blip at the terminal end of the QRS. So this is how a typical AVNRT looks like, that the antegrade slow conduction leads to a very long PR interval, and a retrograde fast conduction gives rise to a very short RP interval, giving rise to this like a blip here in the S wave, or else a pseudo R pattern in the V1, giving rise to a typical AV nodal reentrant tachycardia. Antegrade conduction through this green slow pathway, retrograde conduction through a fast pathway. Okay, so this is how typical AVNRT looks like. Clinical features are very classical. Everybody knows about it. But if you do, sometimes you have you get a patient who has had a Holter of AVNRT, you may see that sometimes these patients will have a variable PR interval depending upon whether slow pathway has conducted antegradely or a fast pathway. If a fast pathway has conducted antegradely, you will have a shorter PR interval. If your slow pathway has antegradely conducted, it will have a longer PR interval. Then you may see sometimes AV nodal echoes, and you may sometimes see that 1P has given rise to 2 QRS, which is also a very uncommon thing to see, but that is because of both slow and fast pathway has conducted, giving rise to a variable PR with 1P giving rise to 2 QRS. Coming to one another variant of AVNRT, which is atypical AVNRT. In this atypical AVNRT, the sequence of depolarization across the node changes. The antigrade limb is usually fastest and the retrograde limb is slower. So let's see how does it happen. So antigrade limb is relatively faster, and the retrograde limb is relatively slower. But this variety is a slow variety. So what is happening is there is a P wave which is submerged in the QRS. There is a P wave which is in between the two QRS. Supposedly, this is a P wave. Antigradely, it is having this PR interval, which is shorter, and the retrograde RP interval is longish. So the P wave is clearly discernible in between the two QRS. So P wave is very clearly visible in between the two QRS. And what are the differential diagnosis to it? Most common, it can be a typical AVNRT. It can be a retrogradely conducting pathway, which has got a retrogradely slow conducting pathway. So it can be a PJRT, or it can be an atrial tachycardia, which is arising from, as this is negative in lead 2, it can be an atrial tachycardia arising from the lower part of the heart, maybe a coronary sinus austin. So these are the three differential diagnoses. When you have a negative P wave in lead 2-3 AVF, which is clearly seen a regular narrow complex tachycardia, and the RP interval is long. So this is how a typical AVNRT usually manifests as. Okay, so this is another very important and very uncommon variety of tachycardia, where you can see that this is supposedly this is a P wave. This is giving rise to one QRS, and then this is giving rise to a second QRS. This P wave giving rise to one QRS, this P wave giving rise to second QRS. And you can see that this tachycardia is not regular. It is actually an irregular tachycardia. These two QRSs are closer to each other. These two QRSs are actually farther to each other. So meaning that this P wave through the fast pathway is giving rise to this QRS, through a slow pathway giving rise to this QRS. This P wave giving rise to this QRS through a fast pathway, and to the slow pathway is giving rise to this QRS. So this is a dual AV nodal variety of non-reentrant tachycardia. There is no re-entry happening. Each P wave is giving rise to two QRS because both the antigrade slow and fast pathway are getting activated. And this is very, very rare, but somebody needs to know that one P can give rise to two QRS. Coming to the next, another variety of narrow complex tachycardia, which is a AVRT, and I will be dealing with only orthodromic AVRT because this is a narrow complex tachycardia. So what happens is that there is a pathway which conducts the atria and the ventricle. The connection can be at the level of any place where the annulus is, and the circuit happens when antigradely it goes through the node, the ventricle gets depolarized normally at it is getting depolarized, and retrogradely the pathway conduct to the atria gets eccentrically activated, and the ventricle gets concentrically activated, and that is why the QRS is narrow. It is a macro reentry. Pathway of the circuit consists of a limb of conduction over the AV node, which is an antigrade node, and the retrograde is through the pathway. So this is also a pictorial diagram where a sinus node fires. There is a pre-excitation. You can see 2,3 AVF is slightly positive. Some part is conducting through the node, some part is conducting through the pathway. But what happens during tachycardia is antigrade it conducts through the node, and retrogradely conduction happens to the pathway. This is same patient. When the tachycardia happens, antigrade conduction is through the node, giving rise to this green conduction, giving rise to a narrow QRS, and the retrograde conduction happens through the pathway, and the P wave comes out of the QRS, but not that much. So it is still a narrow or a short RP tachycardia, but you can still see P wave away from the QRS. So this is called as a short RP tachycardia, orthodromic AVRT, antigrade conduction through the node, retrograde conduction through the pathway. What happens if there is a bundle branch block, which happens if there is a pathway conduction happening and bundle branch block happens? So beautifully shown in this diagram is that a left bundle branch block happens and there is a left-sided pathway. What happens is that as soon as the left bundle branch block happens, the duration of the RR interval increases, and as soon as the bundle branch block disappears, the RR interval decreases. This is because if the left bundle branch block happens, the antigrade conduction goes through the ventricle, then have cell-to-cell conduction, and then comes to the accessory pathway. If there is no bundle branch block, antegrade conduction through the left bundle goes directly towards the pathway. So circuit becomes slower, circuit becomes faster if there is no left bundle branch block and the RR interval shortens. Circuit becomes longer if there is a bundle branch block, and that is why the QRS duration as well as the inter RR duration also increases. So this is a very important concept, that if there is a bundle branch block on the same side where the pathway is, the RR interval will increase. Third common variety is atrial tachycardia. It is relatively infrequent, usually seen in patients without structural heart disease, but patients with increasing structural heart disease have higher chances of having atrial tachycardia. This is one tachycardia where there is a chances of syncopes and sudden cardiac deaths also. The most common mechanism is triggered activity or micro reentry. Usually they have 1:1 AV conduction, but variable AV conduction based upon the AV nodal conduction is important. And we need to see the P wave morphology. So this is an example where there's a sinus P wave, sinus P wave, sinus P wave, and suddenly atrial tachycardia starts, an inverted P wave, and the P wave morphology, P wave duration is exactly fixed. And suddenly the patient again goes into some another variety of tachycardia, which is a narrow complex regular tachycardia. So what has happened is sinus P wave giving rise to PACs. This is a atrial tachycardia, and then patient goes into some sort of orthodromic AVRT. So patient may be having two mechanisms of tachycardia in this case. How does a atrial tachycardia happens? It's one focus which fires at a particular interval. This is actually a very, for your reference purposes for the students, this is Dr. Kissler's flow chart to determine what is the common sites of atrial tachycardias. Initially, they gave it in the year of 2016 or 17, but they revised it in 2021. So this is a very important flow chart where you can determine the focus from where the atrial tachycardia is arising based upon the morphology of the P wave. So everybody should have this in their presentations, or if they want to know where the tachycardia is arising from. So coming next important thing is multifocal atrial tachycardia. If you have multiple foci, they will have multiple PR interval. This foci has got a this PR interval. This foci has got a this PR interval. So if every foci has got a different PR interval, the RR interval will also vary, and then it will have a irregular tachycardia. But if you have a fixed number of P waves with clearly discernible morphology, you can make a diagnosis of multifocal atrial tachycardia, but the treatment most of the time remains similar to that of atrial fibrillation. Junctional tachycardia is also another variety of tachycardia where the foci are happening from the AV junctional region. But in this, AV relation and VA relations can be variable. If there is a constant VA conduction happening towards the sinus node and sinus node is suppressed, you'll have a constant VA looking like exactly AV But if the firing from the junction is not able to suppress the sinus node will fire at its own pace, and then you will have a completely VA dissociation. Narrow complex because it's a junctional tachycardia, and a VA dissociation can be seen as it is being seen over here.
Couple of questions, one or two questions from the audience as well as me.
If
we have to, in a wider spectrum of therapeutic approach, if we have to decide or divide them into a AV node dependent tachycardia and AV node non-dependent tachycardia, where adenosine works, how do you classify them?
So how does adenosine work? Important thing is how does adenosine. So I have a very small slide of how does adenosine works on all varieties of tachycardia. So I have put all the varieties of tachycardias over here, and what is the response of adenosine to these. So AVNRT will have termination, AVRT will have termination, atrial tachycardia. See, that's an important thing, like junctional tachycardias and atrial tachycardias usually are not node dependent tachycardias. Means like their firing is not node dependent tachycardias, but as they are in the junction, and they are sometimes adenosine sensitive. So atrial tachycardias may have conversion, junctional tachycardias may have conversions, but flutter and sinus tachycardia will not have any effect by the adenosine, and you will be able to see a beautiful P waves in after giving adenosine because your QRSs are completely separated. So these are four varieties of tachycardias in which these two, that is AVNRT and AVRT, will 100% or majority of the time, if the effect of the adenosine reaches there, they'll terminate. Atrial tachycardias, few percentage will terminate. Junctional tachycardia, very high chances of terminating. but sinus tachycardia and flutter will not terminate, and you will be able to see a nice P waves. So this is the effect of adenosine. And everybody knows the treatment algorithm. If hemodynamically unstable, go for DC cardioversion. If a patient is stable, try vagal maneuvers, try adenosine. Long-term management, in terms of medications, beta blockers and CCBs are the cornerstone, but people have started now using other antiarrhythmic agents, and flecainide is one of the drugs which are orally available in India. Catheter ablation, it's armamentarium of electrophysiologists, leave it to them, but you should know and you should mention because it's a student's program. And Deep has specifically mentioned, this is only one slide, last slide, etipramil.
Sure.
Etripamil. Etripamil is one drug not available in India. It's a L-type calcium channel blocker, non-dihydropyridine type of calcium channel blocker. It is one drug which can be used inhalational, means like you have a nasal spray, 70 milligram, single push. The chances of 60% conversion of PSVT within 30 minutes, 75% chances within 60 minutes, with an average duration, like within 15 minutes, you will have a conversion to sinus rhythm. And the chances is 75%. Usually, the most common side effect is nasal irritation, congestion, and rhinorrhea. And studies, the recent study has shown that it can be used unsupervised, means that patient can carry the nasal spray in their hand if they have very high frequency of having those SVTs and is waiting for an ablation. They can carry that, but it's not available in India. But probably it may be available in near future. That's it. Thank you very much for.
Thank you, Parag. Such an elegant presentation, and I think we'll have a lot of questions because this is such an important topic. But I think we'll go to the second presentation. There is another very, very important topic as far as exam is concerned. And we have none other than Jaskaran, again from Chandigarh, who is going to discuss on the wide QRS tachycardia and its algorithm. We'll have a 15 minutes presentation. Jaskaran, can you share your screen, please?
Yes. Morning, everyone. Am I audible?
Yeah, you are audible. Your screen is, your first slide is not visible. I think we can start in the presentation mode and from the first slide.
Yes.
Yeah.
Is it fine?
Thank you. Yeah. We can see. Thank you.
Morning, everyone. And thank you, Dr. Deep and Dr. Vera, for this opportunity. So I'll stay brief and my presentation is more like a working approach to wide QRS tachycardia. And I'll be discussing principally on the ECG algorithms to differentiate VT versus SVT, a brief management of VT storm, and then a brief word on VT ablation. So we all know that wide QRS tachycardia is a rhythm with a rate of more than 100 per minute and with a QRS duration of more than 120 milliseconds. So it's not so uncommon presentation. And what students would be interested to know is that even up to 40% of EPs get it wrong. So it's not easy. But if you have a stepwise approach to approach it, so you will be able to find the diagnosis. So to discuss the differentials, the first and the most obvious differential is VT. Old data already showed that up to 80% of wide QRS tachycardias coming in the emergency would be VT. However, as many EPs would approach, SVT with aberrancy is not that uncommon. The second group is SVT with abnormal intraventricular conduction. Now, this is a very wide and heterogeneous group. First, most obvious differential would be a patient who is having SVT and a patient who has already baseline left bundle branch block or right bundle branch block. The second differential would be a patient who is having an SVT and develops a bundle branch block because of tachycardia dependence or phase 3 block. The third differential would be a patient having SVT with a baseline WBW syndrome. So the patient has a bystander pre-excitation, and that is why the patient is having a apparently wide QRS tachycardia. And then, of course, you can have antidromic tachycardia. I won't be going too much into the differences because our approach essentially remains similar irrespective of any SVT with abnormal intraventricular conduction versus a VT. And then you have other differences like ventricular pace rhythm. It could be a drug toxicity like flecainide toxicity or amitriptyline toxicity. It could be simply hyperkalemia. And then it could always be an artifact. So there are some basic common myths about SVT versus VT. First, that a wide QRS tachycardia which is irregular is SVT with aberrancy. This is not true because VT in the initial 30 seconds can be irregular. VT associated with inflammation or VT associated with automaticity can be irregular. Second, uh, wide QRS tachycardia that is slow is SVT with aberrancy. Again, not true. There is no particular rate cutoff which can differentiate SVT and VT. Third, a wide QRS tachycardia which is hemodynamically stable is SVT with aberrancy. Again, not true. 50% of VTs are hemodynamically stable, and occasionally SVT with aberrancy can also be hemodynamically unstable. And then again, we tend to look at AV association and think that this is an SVT, which is again not true. Slow VTs can have retrograde 1:1 VA conduction. So all these things should be kept in mind before approaching this scenario. So historically, very briefly, if somebody already has a history of heart disease, they have a prior MI, they have angina, they have congestive heart failure, that is a very strong pointer towards that wide QRS tachycardia being VT. But you, as everyone knows, you can have idiopathic VTs which are in a structurally normal heart. The other is the age. So if you have a young patient, somebody who is less than 35 years of age, he or she is more likely to have SVT, and somebody who is above 35 to 40 years of age is more likely to have VT. But then again, you have outliers. Third, if you have multiple episodes of tachycardia happening over the last 3 to 4 years, you would think more towards SVT with aberrancy as compared to VT. So the problem with the history is, you can falter. So you can use it in a secondary or a tertiary sense, but not in a primary sense. Then in clinical examination, some pointers towards VT is if you have a feature of AV dissociation. Like if you have a Canon wave in the JVP, you have a variable S1, that would go more in favor of VT. And then if you do a vagal maneuver and you are able to terminate the tachycardia, that would be more likely to be SVT. But there are VTs which can terminate after vagal maneuvers, which can terminate after adenosine, which can terminate after DSM or CCB. So you should always keep those things in mind. There is a long list of ECG criteria to differentiate VT versus SVT and aberrancy, and I'll be focusing on the more common initially. So this is something that we often come across in the text. When you have a too wide QRS duration, you would think of VT. Like in case of right bundle branch block, it is said that if your QRS is more than 140, it is more likely to be VT. That number in case of an LBB is more than 160. But again, this is not a sine qua non. It's not an absolute truth. So you should always keep this fact in mind along with other things. Can you have a VT which is actually narrow? So of course, if your VT is coming from the septal, or if your VT is having early penetration in the His-Purkinje system, or your VT is arising near the conduction system, like fascicular VT, you can get a QRS less than 140 milliseconds. So AV dissociation is by far the most important feature which you should be seeing whenever you see a patient and you want to differentiate between SVT and VT. So AV dissociation essentially means that you have sinus rhythm going on along with the wide QRS tachycardia, and so AV dissociation historically has been said that it is seen in up to 20 to 50% cases of VT. However, the number is much more because if you see carefully, you will be able to find AV dissociation in most of the cases of VT. This finding has excellent specificity. If you get it, it's very likely VT. But if you don't get it, doesn't mean it's not VT. So picture this ECG. So you are seeing a QRS, and then you see the pointers. These are the P waves. So these are retrograde P waves. They are coming after every second QRS. So there is VA dissociation. The other most important feature of differentiating VT and SVT are capture and fusion fields. So what is capture beat? Capture beat is essentially during a VT, especially in a slower VT, the sinus rhythm is able to conduct through the VT. So you see a narrow beat somewhere in between a wide QRS tachycardia. And what is a fusion beat? In fusion beat, you have a beat which is slightly narrower than the tachycardia which is going on, but it is not a sinus beat. So if you get capture and fusion beats, again, it's a very specific finding for VT. And but again, if it's not there, it doesn't mean it's not VT. The other most important thing that you need to keep in mind is the concordance in the precordial lead. So on the left side, you see you can get a positive concordance, which essentially means that you have an RS complex in V1 to V6. And on the right side, a more specific feature is negative concordance, where you have QS complexes from V1 to V6. So what is important to keep in mind is negative concordance would mean almost always VT, because negative concordance means your tachycardia is coming from the apex of the heart, and what is there on the apex? Apex is made up by the ventricle. However, positive concordance would frequently mean VT, but it can also come from a, a pathway, from a left posterior pathway, which is conducting antegrade. Like this ECG, all DM students would appreciate. This is a patient with AF and pre-excited AF, and you can see you have V1 to V6 positive concordance, but this is indeed antidromic AVRT. So next is the morphology criteria. Among morphology, we have discussed the first point, that is the duration. You should not read too much into the duration. You should look at the morphology carefully. So first, what about RBB? We know RBB has an RSR in V1 and a RS complex more than equal to 1 in V6. Any deviation from that morphology in case of an RBB would take you towards a differential of VT. Like if you get a QR in V1, or you get a monophasic R in V1, or you get a rabbit ear where left is taller than right, you should think of VT first. Similarly, in V6, normally your RS should be more than equal to 1. If it is less than 1, or you get a QS, you should again think towards VT. What about LBB? So LBB again has a RS complex in V1 and a monophasic R in V6. But in case of a VT, you would have a very slow conduction through the myocardium, cell to cell conduction through the myocardium. So you would be having a R wave, initial R wave, which is broad. It is around 40 milliseconds. And then you would have a slur in the downstroke of the S wave. In V6, one can appreciate the presence of a Q. So in a typical LBBB, you would not get a Q in lead 1, V5 or V6. If you're getting a Q again, it would go towards VT. So let's see some examples. This is a patient who is having a very fast regular tachycardia, and one would appreciate if you see V1 carefully. In V1, you see that initial upstroke R wave is very brisk. Similarly, you do not see any slurring or notching in the downstroke. And in V6, you see a monophasic R. So all these features favor HVT with aberrancy, with LBB aberrancy over VT. On the contrary, you see this tachycardia relatively slower but regular. So here you see a precordium V1 where there is a QR. A QR is not a typical RBB presentation. And in V6, you see a small r capital S with a ratio of less than 1. So both these features suggest that this is an atypical RBB, and one should think of VT first. Another presentation, another ECG, where you would probably, and at the first instance, think that, okay, V1 has an RS and V6 has a monophasic R, so this should be like a typical LBB aberrancy. But if you see carefully, you see the initial upstroke of the R wave, it is very slurred. It is more than 40 milliseconds. And then you see the downstroke, you see a notch. So both these features would suggest that this is a cell-to-cell conduction and not a typical LBB. So you would think VT first. So you have multiple criteria given over the last 15 years. You have Brugada criteria, Vereke criteria, but I would advise all the DM students not to mug up these criteria, but to have a systematic approach. Brugada criteria is nothing but what we actually have discussed. First, you look at The concordance, if there is a QS complex is all throughout, it is VT. The absence of RS complex basically meaning that you don't have uh, concordance. So the other thing is to look at R to S interval, which is again talking of cell to cell conduction versus an aberrant pattern. And then you can see about AV dissociation and the morphology criteria. So this is the original slide from the Brugada's paper, and where you can see that if you have, these are all patients with VT. So you'd see in first example, you see you have QS in V1 to V6. So our essential workflow in differentiating SPT and VT would first be looking at AV dissociation. Second, looking towards capture and fusion beats. Third would be to look at Brugada criteria and see for positive or negative concordance. Fourth would be to identify whether it's an atypical LBB or an atypical RBB. And last would be to have an AVR look. So let's go towards how to approach a patient with VT storm. VT storm is not an uncommon scenario. However, it's a very difficult scenario. It's very common among patients who have an ICD for a VT, understandably so. And you can have various presentations. You can have presentation with monomorphic VT, a presentation with VF, a presentation with combination of VT and VF, or with polymorphic VT. So how do you define it? It is essentially 3 or more episodes of VT, VF, or polymorphic VT happening 24 hours. In patients who have an ICD, it can be defined in terms of 3 or more ICD discharges in 24 hours. So you can have 3 ATPs in 24 hours. It could still be a storm. You could have 3 shocks in 24 hours, and it could still classify as a storm. So to understand the management, you should understand the triad that leads to an VT storm. The first thing is the substrate. Substrate is a patient who has had an MI, a patient who has HCM, RCMP, or sarcoidosis, a patient who has long QT syndrome or Brugada syndrome. So that is a substrate. Then what is a trigger? Trigger is essentially an event which leads to beginning of the VT storm in that susceptible substrate. And then you have a messed up autonomic system, that is a sympathetic overactivity. When these three factors factor in together, and then that leads to VT storm. So your management would be first, if a patient has an ICD, you use that ICD to determine whether it is VT, polymorphic VT, or a PVC coupled VF, and then simply deactivate the ICD, especially if the VT is stable. Why? Because more shocks lead to more pain. More pain leads to more sympathetic overactivity, and more sympathetic overactivity leads to continuation of the VT storm. So next is targeting the trigger. That is very important. First, rule out ischemia in all the cases. If there is ST elevation or depression, you go for revamp, especially in cases of polymorphic VT. Second is try to identify what is leading to VT. If there is a constant monomorphic PVC which is leading to PVC, ablation is the treatment of choice. If you're not having ablation, you can use drug called quinidine. Quinidine is available in the Indian market now. Second, what if there is a baseline bradycardia which is leading to VT? That could happen in cases of a complete heart block. So you can get a patient with complete heart block who is recurrently going into polymorphic VT. So in such cases, temporary pacing or isoprene. Then similar scenario in the presence of long QT is called torsades. Again, drug of choice for torsades is magnesium, and using isoprene or overdrive pacing. Then you can get inflammation, especially where you have a VT which is irregular, a VT where there is baseline sarcoidosis or tuberculosis, and you have that very strong suspicion. In that case, immunosuppression is important. Then you have other things like thyrotoxicosis, hypokalemia, hypomagnesemia, infections, volume overload. All these things can trigger a VT storm. Second line is what is the first drug of choice for an as an antiarrhythmic in VT storm? That is beta blockers. So beta blockers can be given in all the cases except when your hemodynamics are severely compromised. And how do they act? They will reduce the sympathetic overdrive, and they have anti-antinergic properties. Which is the best beta blocker to use? It is a non-selective beta blocker, preferably propranolol. Time and again, multiple RCTs have shown that propranolol scores over metoprolol, and you should prefer to use propranolol over in all these circumstances. However, if you have a patient who has a very precarious hemodynamics, you should be using esmolol. Why? Because it's a very short-acting drug and it can be easily cleared out by the body. Second most important drug to use, as we all know, is amiodarone. What we should remember is do not use amiodarone, especially in presence of a thyroid storm or in patients with long QT. So you need to have a liberal IV dosing of amiodarone and you need to keep it continuously on in IV form for at least 48 hours after the resolution of the storm, because more often than not we are undergiving amiodarone, because you need to have at least 2 grams of IV amiodarone in the first 24 hours and a total of 10 gram may be required to get therapeutic effect. So what happens when you are on amiodarone and your weight is not responding? You are in a tough position. You need to think out of the box. Lignocaine can help in certain cases like post-MI cases, but otherwise lignocaine rarely helps. Again, mexiletine is an adjunctive therapy, good for patients with storm in presence of long QTS3, but as such, it doesn't have a great role. So once you are given amiodarone, you should think of other things now. So you should think of sedation strongly. All patients should get some amount of sedation, like fentanyl or midazolam. And if a patient is not responding after amiodarone, you should think strongly of mechanical ventilation. You should avoid propofol for mechanical ventilation. And in the meanwhile, when you are managing the hemodynamics, your go-to drug for hemodynamics maintenance should be norepinephrine and not dopamine or dopamine. Next step, if you have sedated the patient is not responding, you should go for neuraxial blockade, that is blocking the sympathetic overdrive. How do you do it? You can do it on the bedside, you can do it surgically. So I would recommend everyone in the DM group should know how to do this stellate ganglion block. It's a very simple procedure. You just need to have some ultrasound knowledge. You can easily localize the stellate ganglion on ultrasound below the longus colli muscle, and giving bupivacaine in that area can actually terminate a lot of your VT storm. A patient who responds to stellate ganglion block will also respond to bilateral sympathectomy, which is a more advanced procedure. So you should go for sympathectomy, especially in patients who have a long QT syndrome or a CPVT,
Just
or
Karan.
patients who respond to stellate ganglion block.
Yeah.
Meanwhile,
So just you
yeah,
just I mean you have
yeah,
covered
Deep,
two
please.
topics. The last one is VT ablation. Just
Correct.
go through the headings of those VT ablation. You need not just get into the specifics, so that the students, when they go through the headings, they can use these headings to build up their answers when the questions are asked in the exams. Just go back
Sure.
2-3
Yeah.
slides back. Yeah, 2-3 slides back. Just go through the headings so that the students will remember this when they are asked a question on VT ablation. The idea is when a question is asked, they should be able to, they should not go blank and they should know. Yeah, the
Yes.
role of
Yeah.
catheter ablation. Yes, the Vanish trial, something students should look into the Vanish trial, get into the specifics, at least read the abstract of the Vanish trial. And yes, the next one.
So again, VT ablation strategies is, I don't want to go into too much details, but now with
Just go through the headings. Just go
so
through the
you should,
headings.
there are basically two ways of mapping VT. You can either let the VT go on and map the VT, that is called activation mapping, and then in many cases the patient is not stable during the VT, so you can do a substrate based mapping, that is basically identifying the substrate anatomically and functionally, and then you can go ahead with the VT ablation. So
Yeah,
So
we'll just go
I
through
would
this.
suggest everyone to identify patients who respond very well to catheter ablation, especially in cases of VT storm. First is the patient who has a post-MI patient and has been having monomorphic VT despite giving amiodarone. The evidence for this comes from the Vanish trial. Second is the patient who is having the recurrent ICD shock. Third is a patient who is having slow VT. Slow VTs would not respond to drugs, would not respond to ICD shock. So that's an ideal candidate for catheter ablation. And then there are people who have polymorphic VT, which is always induced by a monomorphic PVC. So in that case, you can target the PVC and make the patient free of VT. And third, of course, when you have a patient who is having stable VT and has a relatively preserved EF, you can go in such cases, catheter ablation can have a potentially curative role. So to
That's
summarize,
great.
yeah,
Yeah.
to summarize, basically you need to have a systematic workflow in appropriate in differentiating SVT with efferency and VT. Most important features: AV dissociation, capture beats, and fusion beats. When facing VT storm, stabilize first. Identify ischemia, inflammation, dyselectrolytemia, or thyrotoxicosis. Amidrone and non-selective beta blockers with mild sedation is your first-line therapy. You should have a very low threshold for stellate ganglion block, and catheter ablation is the first-line therapy for patients who are not responding to amidrone or patients who have slow VT and PVC-related VF. And once the patient stabilizes, all patients should get an ICD. Thank you.
Thank you so much, Jaskan. It was a very difficult topic. We tried to cover as much as possible in the given time. We will come back to you
Okay,
if we
Saurabh.
have
Yeah.
some time.
Yeah.
I would like to invite Dr. Anit Vyas now for slightly more complex topic, I would say. So over to you, Dr. Vyas.
Actually, a very important topic from the exam point of view. So, Anirudh, up to you, so that to let the students know if they are asked a question. That's the idea of this whole webinar today. If they are asked a question on this mechanism of erythromogenesis, what are the points they should visit while they write an answer or build up an answer on this one? Yeah.
Going to discuss in techniques about election potentials and its relevance in mechanisms of arrhythmia. At the outset, it appears to be a basic science issue, which of course it is, but it has a lot of relevance in managing patients in day-to-day clinical practice, be it by medical therapy or by catheter ablation. So, evolution of channels, ion channels in our body, as you can see in this slide, from karyotes to present, it has evolved like life has evolved. The major ion currents which are present in any cellular membrane are like displayed, which are the sodium, calcium, potassium currents, and how channel operates from resting to open to again inactivated and again resting state is shown in the left side of the image. Now, what are the currents which are relevant in myocardial action potentials? So these currents are either inward currents or these are outward currents. And mainly it is the flux of sodium ions, calcium ions, and potassium ions. Ultimately, it all depends on the resting membrane potential. How a resting membrane potential is generated in a living cell or tissue is also very interesting. Basically, it is the balance between the chemical or concentration gradient for potassium ions, and it leads to opposing electrical and concentration gradient, which leads to resting membrane potential of roughly around minus 85 millivolts. Resting membrane potential. How action potential is generated? Generation of action potential, it requires depolarization of the membrane potential by a current or stimulus or whatever. And it has to be above a certain threshold value. And if this threshold value is not reached, action potential does not affect. This is the fundamental concept of any action potential in the body. And it is relevant as begin from generation of action potentials in the sinus node to propagation of action potentials down the AV node and even in the mechanisms of arrhythmia. Now, action potentials in sodium channel dependent cells are the action potentials which is usually studied. As far as heart is concerned, they are precisely from the Purkinje muscle fibers. There is certain variations from sinus node to AV node to Purkinje fibers to myocardial selection potentials, but principally the four-phase action potential, five-phase action potential, where 0, 1, 2, 3, and 4, which we see in learning physiology and in the pathology issues, they are all which comes from the Purkinje fibers. Now, when we see sinus node, atrium, and Purkinje, and the ventricular myocardial action potential, we clearly see that it is these sodium, calcium, and potassium channels which play a role in generation of such potentials in the memory. Now, there is subtle variations in each of them. So sinus node is a tissue where spontaneous depolarization occurs. It is a unique and interesting place in the heart where slow spontaneous depolarization, which brings the membrane potential from its most negative point at the end of depolarization to the threshold potential at the onset of next action potential. So it results from hyperpolarization activated sodium current, which is called as funny channel, and they are principally mediated by calcium channels. So um, this leads to spontaneous depolarization and the generation of action potential in the heart. It is not limited by any external stimuli, but it is the spontaneous depolarization which actually is responsible for beating on the heart. The shape of sinus node action potential looks like this. AV nodal cells, which are called in the end regions of the AV node, they have slightly variable action potentials compared to sinus node, but they are more like sinus node action potentials rather than the Purkinje fiber action potentials. Maybe that is why AV nodal cells also have the property of spontaneous depolarization. And in fact, when we see that sinus node is suppressed because of disease, like sinus node dysfunction, or during AV block, more often we see accelerated or escape rhythm from the AV nodal cells. So that is how, because of these spontaneous depolarizations, escape rhythm can come. And then there are these interesting M cells in the middle myocardium, which have longer action potential durations, and they have relevance in long QT physiologies and pathologies. Now, why this normal action potentials? Principally, as we are concerned with the generation of action potential, cardiac arrhythmia can be because of normal automaticity. Normal automaticity occurs when there is accelerated sinus tachycardia. Abnormal automaticity occurs when there is arrhythmia after myocardial infarction. And then the second mechanism is the triggered activity, which leads to early and late depolarization, early and late after depolarization, which eventually lead to prolongation of the repolarization durations. So this is the principal pathology. Abnormal automaticity and triggered activity is the principal pathology behind arrhythmia arising because of action potential generational abnormality. Then we all understand that EADs occurs more often in Purkinje fibers and also in the M cells, and they are important in the long QT congenital long QT syndromes, while delays implicated in arrhythmias associated with Johnson's toxicities and also in idiopathic outflow tract VTs, and that is why adenosine and they are considered to be adenosine sensitive. As far as the figure is concerned, the early and late after depolarization, they appear like this. And the adenosine sensitivity of these delayed after depolarization is depicted in this figure. Most often, in clinical circumstances, we don't see abnormalities of action potential generation leading to arrhythmia. More often, it is the propagation of action potential which is relevant in mechanisms of cardiac arrhythmia. So, equal to generation or mechanism of formation of action potential, it is equally relevant to understand the propagation of action potential. What do you mean by propagation of action potential? It is the depolarization current which is generated by the first action potential and it propagates electrotonically to the next cell. And that is how the impulse is propagated. Now, there are certain fundamental axioms about exponential decay, which I'm not going to go into detail, but it principally is responsible for the source sink hypothesis, which we see in our day-to-day practice of arrhythmia mechanisms. So, from where the current is flowing is called a source, and the cells which are downstream, which are depolarized later, is called as sink. Now, whether the current will flow from source to sink and whether the sink will be depolarized normally or abnormally depends on the safety factor, and that is how successful propagation occurs. The current generated by the proximal portion, the source, is determined by maximum rate, maximum amplitude, and also the action potential durations. And all the antiarrhythmic drugs, when they are relevant in managing arrhythmia, they act on these three mechanisms. Sink hypothesis is beautifully depicted in this diagram. Source tissues are less, they may not be able, they may not be enough to depolarize the sink, and also the traveling wavefront of the source is also relevant in whether it is able to depolarize the region of sink or not. So other than source sink hypothesis, this is another interesting concept in propagation of action potential, and this is the direction dependence. So we all understand, we all know that myocardial cells are arranged longitudinally and they conduct with a speed in longitudinal direction compared to transverse direction, and this is simply called as anisotropy. So that anisotropic propagation means that the conduction is compared better in the direction of long axis. Now, but still, the relative resistivity in both longitudinal and transverse direction may vary, and hence the safety factor may vary, and this may actually lead to delayed conductions or unidirectional block in longitudinal conduction, and that is important in generation of the third most important mechanism of arrhythmia, which is re-entry, which we usually see in our day-to-day practice, be it atrial flutter, be it AVNRT, be it tachycardia associated with WPW, or the various forms of SCAR or structural VTs. So re-entry, it is the circulation of cardiac impulses around an obstacle, which leads to repetitive excitation at a frequency that depends on the conduction velocity of the impulse and the perimeter of the obstacle. There are three principal requirements of re-entrant activity to occur. There has to be a circuit. A circuit can be enacted, like we see in the WPW, pathway going down, conducting up. And there has to be a need of unidirectional block, and then there has to be a zone of free conduction so that the traveling wavefront keeps on conducting. The circuit can be anatomic, it can be functional. For example, in patients who have WPW and atrial ventricular fibrillation, respectively. Now, this figure depicts how an anatomic re-entry circuit is relevant in generating an arrhythmia. This is an example where accessory pathway leads to generation of re-entrant circuit leading to orthogonal re-entrant tachycardia. Yet we have to be very clear that the barrier, the conduction barrier, may not always be anatomic, it can just be functional as well. And how do you see the temporal and the spatial parameters of re-entrant wave like this in this figure? And the functional re-entry, again, can be of two types. One is the one where there is no excitable gap, and there is one where there can be excitable gap. And these are two different physiologies for re-entry, which is in generation of tachyarrhythmia. I'm not going to go into much detail because of constraints of time, and would end my presentation by this slide, which depicts classification of arrhythmia mechanisms. There are ways by we can identify the type of mechanism of arrhythmia, whether it is automatic, whether it is triggered, or it is re-entry, and programmed stimulation after depolarizations and adenosine sensitivity are the tests which can be utilized to understand what type of arrhythmia it is. Arrhythmia mechanisms are relevant in choosing the type. For example, automatic rhythm require a different set of antiarrhythmic mechanism. A triggered activity may require a different mechanism. anti-arrhythmic drug selection. Mechanism would require with different mechanisms. It is also relevant to for selection of such patients for catheter ablation, to map the circuit and to ablate to offer a better cure, a better treatment for these patients. So, however, or howsoever sort of boring the fundamental science may appear, these are the roots, these are the axioms from where we rectify and we build the clinical field. So it is always relevant and important to understand basic fundamental mechanisms of action potentials and arrhythmia generation. And this may help us, of course, at one way, the DNB students and DM students to impress your examiners. And secondly, also to treat your patients well in future. I wish you all the best. Thank you.
I think it's again a very complex topic, and we always think that how we can get better understanding of this. So I think we'll go to the next presentation, and then we'll come back and combine these two topics to have the questions. So next we invite Dr. Abhinav. Can you share your slides, Abhinav?
Okay.
Yeah, we can
Good
see
morning,
yours.
everyone. First of all, I'd like to thank IHRS, Bera sir, Deepchand Raja sir for giving me with this opportunity to present here. So, my topic is genetic channelopathies, which are Brugada, long QT, and CPVT. And this is going to be just a broad overview of all these three topics because the idea is to give you an overview upon so that whenever you're faced with these in the exam you can attempt them. So we'll start with Brugada syndrome. So mainly what I'm going to do is discuss the guideline recommendation. These are mainly taken from ESC 2022 guidelines. So you can just concentrate on the lecture, and if you want to read further, you can go back and look at the guidelines. So we start with Brugada syndrome. So Brugada syndrome is diagnosed in a patient with spontaneous type 1 Brugada ECG pattern and absence of structural heart disease. Let's see why this is important. So this is the Brugada ECG pattern. So three types, type 1, type 2, type 3. Out of this, only type 1 is diagnostic of Brugada syndrome. So let's look at the type 1 ECG. So here, as you can see, there is no clear R wave in V1. Then the J point is elevated in V1 and the J point and ST segment has a high takeoff here, which is more than 2 millimeter. Then the ST segment is cove and the T wave is negative and symmetric. If you look at V3, you will also realize that there is a QRS duration mismatch. Now, this will not be evident in all the cases, but here the QRS in V1 appears more in than in QRS in V3. Now, compare the type 1 with type 2 and type 3, where there is going to be a J point elevation, a ST segment elevation more than 2 millimeter J point elevation, ST segment elevation more than 1 millimeter, and a saddleback appearance followed by positive T wave in V2. And type 3 has either a saddleback or a coved appearance, but the ST segment elevation is less than 1 millimeter. Now, out of all these three, only type 1 is going to be diagnostic of Brugada syndrome. The other things that the guidelines say is the patient should have structurally normal heart. Now, this is because The underlying pathophysiology is either the activation delay in the RVOT subepicardium or a transmural dispersion of repolarization. Now, all the structural heart disease that give rise to a delay in conduction in the RVOT epicardium can give rise to a ECG which is similar to the Brugada syndrome. So before you diagnose any patient with Brugada syndrome, the first step is to rule out the presence of structural heart disease. This includes acute myocardial ischemia, especially of the right ventricle, pulmonary embolism, which will again manifest as a delay in conduction in the RVOT. These group of muscular dystrophy, if there is a mechanical compression, for example, rectus excavator or mediastinal tumor, this can give rise to a Brugada pattern ECG, but this is secondary to a underlying structurally abnormal heart. Now, other term that you must know is a Brugada phenocopy. Now, this may be secondary to, let's say, hyperkalemia, which is causing delay in conduction in the RVOT epicardium. So, this is characterized by a Brugada-like ECG, identify underlying condition, and once you correct this, the Brugada pattern disappears. We'll come to these 3 points later. So, because Brugada ECG is uncommon, if you have a spontaneous type 1 and a structurally normal heart, you say that this patient has Brugada syndrome. However, if the patient is symptomatic and the symptoms may be a cardiac arrest due to VF or polymorphic VT, or it may be a arrhythmic syncope or nocturnal agonal respiration. A patient may have a family history of Brugada or a sudden cardiac death in less than 45-year-old with circumstance suspected for Brugada. So in these patients, when you don't have type 1 Brugada pattern on ECG, you can do a provocative testing using a sodium channel blocker, or this may appear during fever. Now remember that if you have a type 1 Brugada ECG pattern already, then provocative testing has no role. Okay, so now we come to management. So I'm quickly going through for so that we can cover all the topic in the 15 minutes. So if you have a patient with Brugada and a spontaneous Brugada ECG, then there are 3 recommendations that you're supposed to do in all the patients. So this is avoid drugs that can give rise to Brugada type pattern, avoid cocaine and alcohol intake, and whenever this patient has fever, you're supposed to aggressively treat the fever. Apart from these general recommendations, the further management depends whether the patient is symptomatic in the form of syncope or nocturnal agonal respiration. If the patient has syncope, which is determined to be arrhythmic in origin, or if the patient has a cardiac arrest, then the patient should undergo a ICD implantation. Next, we come to long QT syndromes. So these are characterized by delayed repolarization, which manifest as QT prolongation on the ECG. And these patients are at an increased risk of syncope, seizure, or sudden cardiac death. Now, this should occur in the setting of a structurally normal heart in otherwise healthy individual. So, how do we diagnose this? This is diagnosed by the modified long QT diagnostic score, which is based on 4 main parameters. So, you should look at the ECG, clinical history, family history, and do genetic testing. Now, once you add up this score, if it is more than 3, then it is diagnostic of long QT syndrome. So what I want you to look here is these two itself give rise to 3.5 points. So if you have a patient with a QTC more than 480 milliseconds in repeated 12 lead ECG, or if you have a pathogenic mutation, then irrespective of the QT duration, you call this patient as a patient with long QT syndrome. Now coming back, we'll look at these ECGs so that you have an idea of how they look like, and you can recognize them once they present to you. So this is an ECG of Torsades de Pointes. This is T-wave alternance. So this we published in the heart rhythm case report. So if you look at the ECG here, there is a T-wave alternance, that is variation in morphology, polarity, and amplitude with a sinus rhythm T-wave without variation in the QRS complex. Now this is a marker of ventricular repolarization, regional disturbance, and this may precede ventricular fibrillation. So these patients are at a high risk of VFib. If you look at the TDP ECG here, you can see that there is a macro wave T wave alternance. So this increases before the patient goes into the torsades. Now these patients with long QT may also have notch T waves in more than 3 leads. This is most common in long QT type 2. And these are the genetic types. So this is a long list, but you are supposed to concentrate on these three, that is long QT type 1, 2, and 3, because almost 75% of the patient with long QT will have mutation in one of these three channels. This is an exam question. So what you have to know is patients with long QT are almost always asymptomatic unless they have a trigger which can give rise to a lethal event because of TDP. Now, the trigger in long QT type 1 is going to be exercise. Swimming is the most common exercise which is associated with this. In long QT type 2, this is going to be emotional stress, auditory stimuli, for example, waking up suddenly from an alarm or in a postpartum state. And for long QT3, this can occur in sleep in about 64% of the patient. Long QT1 is going to be most common, and the ECG of these three are long QT1 will have a broad-based T wave, 2 will have a notch, and in 3 you will have QT prolongation, which is mainly contributed by the ST segment. So management, general recommendation to be followed in all the patients, avoid QT prolonging drugs. If you have a patient with electrolyte abnormality, let's say hypokalemia or hypomagnesemia, you're supposed to aggressively correct it and avoid genotype specific triggers for arrhythmia, which we just discussed. Now let's come to the specific management. So this will depend on what the patient presents to you with. The general recommendation is to be followed in all the patients. Now, beta blocker is also to be started in all the patients. However, if the patient is asymptomatic, only pathogenic mutation, but no QT prolongation, the beta blocker is going to be class 2A. In all the rest of the presentation, this is class 1. Beta blocker that has to be given in these patients is going to be non-selective. So you have two options. One is nadolol and other is propranolol. Nadolol is not available in India. So the only option that we have is propranolol. In patients who have long QT type 3, which is associated with SCN5A mutation, you can add mexiletine, and this is class 1. Again, if you have a arrhythmic syncope, then or aborted cardiac arrest, then ICD becomes class 1 indication. If the medical therapy is not tolerated, then the patient may undergo left cervical sympathetic denervation. Okay, so coming to the last one, that is catecholinergic polymorphic VT. Now, these are a group of disorders which are familiar polymorphic VT. So if you look at this chart, the CPVT1, which is caused by rhinodine receptor 2 mutation, this is autosomal dominant. This accounts for around 50 to 60% of the patients, and therefore this will be familiar. The presentation may be as a sudden cardiac death in a patient less than 40 years of age. However, the mean age of presentation is 7 to 9 years, or the presentation may be due to syncope. What you also may know is this is most commonly autosomal dominant, but may be present as autosomal recessive. This is rare. We presented a case in heart rhythm, and you can go and look at it for those who are interested. Now, the exam topic is this. So the classical presentation of CPVT is with bidirectional ventricular tachycardia. Things that you should know is the other differential of bidirectional ventricular tachycardia are long QT type 4, Anderson-Tawil syndrome, which will be characterized by QTU prolongation. Digoxin toxicity and acute coronary ischemia may also give rise to bidirectional ventricular tachycardia. Now, these patients with CPVT will have normal resting heart and ECG. So exercise testing is going to be the most important step. These will have their own threshold rate, after which they will have a monomorphic ventricular beat. Now, what the monomorphic ventricular beat does is it shortens the RR, and this causes a beat which arise a DAD induced, which is delayed after depolarization induced beat in a different area of the heart, which may be a His Purkinje or from the ventricle, and this will give rise to a 180-degree alternating axis in one of the limb leads, which gives rise to a bidirectional ventricular tachycardia. Now, if you don't stop at this stage, patient may go into VF. Okay, so treatment is beta blocker, ICD with flecainide, and left cervical sympathetic denervation if you are not able to control with it. Thank you.
Thank you, Abhinav. You finished almost in time.
16 minutes. Sorry for the one extra minute.
No issues. So, do we have time for a question or two? Maybe for the first 3 lectures?
Okay, that's fine. So it's more of the exam-related questions. I think they would have, hopefully, students would have taken notes and of what they need to revise and go through. Good. So Deb, we okay to move to the next session, Deb? And Saurabh?
Yeah.
If there
Do
are
we
no
have
questions,
a time for a question or two, sir? Exam-related only?
Yeah. If they, anyone who is
I think there are a few in the chat box that have been answered by the people who have given the lecture. If Dr. Parag is around, I would like to ask him a question or two which are relevant to the exam going student. Is he around?
See, Saurabh, you yourself can answer this. Difference between entrainment and overdrive pacing. This, I think, is an important question to be explained to the students. You can take a minute or two to describe this, Saurabh. Difference between entrainment and overdrive pacing.
So the basic difference, entrainment and overdrive pacing are two different concepts. Like as we discussed, the mechanism of arrhythmia, it depends on what type of mechanism are we dealing with. So overdrive pacing is basically what you are dealing with is a focus which is there, and you are trying to override that focus with whatever you are pacing. So if the tachycardia is going on at the rate of say 280 milliseconds and you are having a rate with your pacing of around 270, 280, 260 milliseconds, and you basically override that focus and stop that arrhythmia at that point of time. Whereas entrainment has 4 definite points which have to be there to call it entrainment. Basically, what we are dealing with is a re-entrant circuit, and in that circuit we try to get in with our pacing. So if the circuit is going on at the rate of around 280 or 290, as we discussed before, your entrainment cycle with at 270 or 260 basically entrains, that increases the tachycardia to your pacing cycle length, and you basically get inside the circuit which is going on, and you have certain criteria post entrainment which can help you diagnose that particular type of arrhythmia. That is a basic difference between entrainment. So entrainment and overdrive pacing. I hope people have understood that.
Yeah, so entrainment is just an outcome of overdrive pacing, and overdrive pacing is a means of achieving entrainment. And not to get into the specifics of entrainment and the entrainment criteria, but this is broadly as Dr. Saurabh had put forward. So I'd see Jaskaran answer a few questions in the chat box. So mechanism of arrhythmogenesis, can you please suggest the source? Source, Brownwall should be fine. You should be able to get into the mechanisms arrhythmogenesis chapter in Brownwall, and you can go through the chapters. But for some reason, again, the textbook reading should be there. There's no substitute for textbook reading. I don't think people should look forward to articles. I see a couple of questions coming. Which article, this article, that article? Why do you look for articles when you have textbooks in front of you? So you have Hurst, you have Brownwald. Kindly get to the textbooks. You have all the answers in the textbooks. Stick to the chapters. You will have answers there. Okay. Then anything else? That in the chat box, I see our people, the panelists typing a few answers. So we will not get into those questions. Saurabh is typing an answer for the management of Brugada Fleckeni challenge. Okay, good. I think we should move to the next session. Saurabh, I will allow you to continue type answers and continue answering those questions up in the chat box and the view as well. So let's move to the next session 2, where I invite the moderators, expert electrophysiologists and teachers in their own institutions, Dr. Ayush Shukla from Lari Cardiology, Lucknow, Institute Lucknow, and Dr. Anunay Gupta from Safdarjung, New Delhi. So welcome, Dr. Ayush and Dr. Anunay. Are you both on board now?
Hi, Deep. Thanks.
Hi, Anunay. Hi, Anunay. And Ayush, yourself? Yeah, I see you there as well.
Thanks,
colorful background, Ayush. Thank you. Wish you both a happy Sunday, and then I will allow you both to take over. You have 4 topics to cover. Please go on.
Yeah. Thanks, Deep, for inviting us and carrying on the session 2, in which, hello, Dr. Anunay.
Hi, Dr. Ayush.
So I think you can invite the first speaker.
Yeah. So, in interest of time, I would like to invite Dr. Shirish for his interesting talk on ICDs for primary and secondary prevention, evidence and current guidelines. I think it will be quite useful for our DM and DNB students.
Sure.
Thank you, Dr. Avnay. Can I share my screen?
Yeah.
Yes, not available.
Okay. Good morning, everyone. My name is Dr. Sirish. I'm Associate Professor at CMC Vedur. I'll be talking about ICDs for primary and secondary prevention, evidence behind the current guidelines. So most of you already know what ICDs are and what ICDs do. What I'll do is quickly go through the evidence and how the evidence evolved that form the basis for the current guidelines, brief history of ICDs, and also evidence and the difference in evidence between non-ischemic cardiomyopathy versus ischemic cardiomyopathy. When I use the term non-ischemic cardiomyopathy, we know that it's a very broad term, but I'll be confining myself to patients with heart failure with reduced ejection fraction. I won't be dealing with hypertrophic cardiomyopathy or ARVC, which by themselves form a separate topic. So when I mean NICM, it means a non-ischemic dilated cardiomyopathy. And also, I'll just briefly discuss about ICDs in ischemic and non-ischemic cardiomyopathy. patients who do not clearly fall into the like typical patient included in the trials. So to start with, the earliest ICD development started in 1969, 1970 by Dr. Mirowski and Mover, and it took them about 10 years to show the efficacy despite a lot of resistance that it's effective in animals. And 1980, the first ICD was implanted epicardially, so it required a thoracotomy and an epicardial patch was implanted. And the first FDA approval was given in 1985. So most of these patients were highly selected patients who had cardiac arrest previously, survivors of cardiac arrest. Because of the morbid nature of the surgery, there were very few takers during those time. So the only patients who really underwent the ICDs were patients with who already survived a cardiac arrest. For the next 10 years or so, the epicardial ICD had few takers, and the antiarrhythmic therapy with amiodarone remained pretty much the standard of care for most other patients. With the advent of transvenous leads in 1993, the whole field changed with the much less morbid surgery. The indications and the ability to try for new indications among the investigators also has increased. And after that, a slew of randomized controlled trials were done, which established ICD as beyond doubt as a therapy which saves lives. So initially, the most patients were included based on the degree of heart failure and the ejection fraction, and they were included based on that, and they still remain the inclusion criteria for most patients for ICDs. So as with anything, the highest risk patients undergo trials to start with. So in secondary prevention, those patients who already had a cardiac arrest or had sustained ventricular arrhythmias. The AVID, CASH, and SIDS were the most important trials that were done. CASH and SIDS were done in the era of epicardial ICDs. They started in somewhere in 1989-90. Because of the slow recruitment, they took much longer and they were published much later. So AVID is the one which was mostly transvenous ICD, which started later, but because of the faster recruitment, which was finished first, and the results were published earlier. So in patients with ischemic cardiomyopathy, any cardiomyopathy with who have survived cardiac arrest or sustained ventricular arrhythmias, they were randomized into ICD versus antiarrhythmic therapy, which were amiodarone or sotalol. There was a 31% reduction in all-cause mortality. This was the first trial which has shown the benefit of ICD in a randomized trial, and which has started the era of randomized controlled trials in the ICD. The CASH and SIDS, even though they started earlier, were published much later, and the meta-analysis of all these trials has shown a significant 30% reduction in total mortality and almost half reduction in arrhythmic mortality in patients who already had a cardiac arrest or sustained ventricular arrhythmias. So at the same time, almost simultaneously, this is interesting. In generally, it's usually the higher risk. Once it's proven it, they go to the lower risk patient. But because of the nature of the illness, that's a sudden cardiac death, the primary prevention trials almost took simultaneously. They were done simultaneously along with the secondary prevention trials. So the most important I would touch upon is MADIT and the MUST, which were published in 1996 and 1999, almost simultaneously with the AVID trial. So what these two trials, the multicenter automatic defibrillator trial and the multicenter unsustained tachycardia trial, they have included patients with prior MI, that's again ischemic cardiomyopathy, slightly different inclusion criteria of ejection fraction less than 35%, 40%. But they had the inclusion criteria that these patients need to have non-sustained VTs, and all of them underwent EP study for inducible VT. Those who had inducible VT was not suppressed with procainamide, they were randomized. There were slight differences in the recruitment, but the gist is that they had all underwent EP study for it, and who had inducible VT went on to get an ICD, were randomized to ICD versus medical therapy. So there was a 30% reduction in these patients as well. So the observation post these two trials, the observation that were done was that even in those patients who had negative EP study at the time of recruitment, there was 24% incidence of sudden cardiac arrest over 5 years. So then we realized that the ejection fraction is probably the single most important determinant of the sudden cardiac death, irrespective of whether the patient had NSVTs, whether the patient had non-sustained VTs or inducible VT on EPS. So they designed this MADIT-2 trial, which was published in 2004, which simplified the inclusion criteria, which they took all patients with prior MI, ejection fraction less than 30%, were randomized to ICD versus medical therapy. And in these patients, despite absence of non-sustained VT or sustained ventricular arrhythmia, there was still 30% reduction in mortality. So this is more contemporary way of recruiting patients for ICD therapy. Now, the next most important trial was sudden cardiac death in heart failure trial, SCD-HEF trial, which again included patients with ejection fraction less than 35%. Of any cause, no need for NSVTs or VT inducibility. Almost half of them were non-ischemic dilated cardiomyopathy, which showed 23% reduction in mortality. Now, there are two important negative trials which form again the guidelines. They give us important pieces of information that form the current guidelines. One is CABG patch trial, which was done in 1997. These are the patients who had severe coronary artery disease with an ejection fraction of 35% going for CABG. They were randomized at the time of CABG to either medical therapy or an epicardial ICD, which showed no benefit. So the reason that is considered why there was no benefit in this particular group of patients was the protective effect of revascularization. Revascularization in these patients with ejection fraction less than 35% itself improved the ejection fraction, and also it was protective against sudden cardiac death. So that forms the basis for the current guidelines, which say that you need to wait at least 3 months, that's the recommendation, 90 days after revascularization to plan for an ICD after seeing the improvement in ejection fraction. The second important negative trial was Dynamic, which was published in 2004, where patients after a myocardial infarction were immediately randomized to ICD versus medical therapy immediately, that is 6 to 40 days, if the patient at time of discharge was less than 35%, which again did not show benefit of ICDs. So this again forms the basis for the reason probably is because of multiple analysis shown that so early after the MI with ejection fraction of less than 35%, they're more likely to die of non-arrhythmic causes like heart failure, progressive pump failure rather than just arrhythmic. So the overall mortality was not altered by ICD. So this forms the basis that to wait for at least 40 days after an MI to see if the ejection fraction improves with medical therapy alone before deciding on the ICD. So to summarize, the current guidelines, more contemporary way of recruiting patients was mainly based on AVID. There was no doubt about this. This all patients who had sustained VT or VF or sudden cardiac arrest survivors had mortality benefit. So ejection fraction less than 30% had definite mortality benefit irrespective of NYHA class 3 in ischemic cardiomyopathy. Whereas patients between 30 and 35%, if the heart failure was more severe, they had more benefit. So the 4 important factors which determine ICD indications in the current era are that 1, the severity of left ventricular systolic dysfunction, that is ejection fraction less than 30 or 35%. Severity of the clinical heart failure, whether patient is in class 1, 2, or 3. Most of these trials have excluded class 4 patients because of their extremely high mortality due to pump failure rather than arrhythmic death. So the general recommendation is ICD is not recommended in patients with class 4 who is not improving with medical therapy. The etiology of LV dysfunction, that is ischemic, non-ischemic, I'll just briefly discuss about why non-ischemic, there's a difference in the evidence, and of course, life expectancy. So just to summarize the current guidelines, if the patient has more than 1 year life expectancy, and if patient already had any of these, either stable VT or cardiac arrest, then obviously ICD is a class 1 indication. If the patient has had MI or non-ischemic heart disease, more than 40 days post-MI or more than 90 days revascularization, if the EF remains less than 30%, irrespective of the heart failure severity, that patient has a class 1 indication of ICD. If the ejection fraction is between 30 to 35%, again, another factor of whether the patient has heart failure symptoms, again, that forms a class 2A indication for an ICD. Practically, most patients with ejection fraction less than 35% with ischemic cardiomyopathy receive an ICD. That's simple. There's no controversy about ICD in ischemic cardiomyopathy. The controversy or probably evolving evidence is mostly in the non-ischemic dilated cardiomyopathy. Now, even the earlier trials, the benefit was, in at least some trials, was not as much as an ischemic cardiomyopathy. So there is, and the much later trial, as I discussed, have shown no benefit in some of these patients. So the reason for this is probably because non-ischemic diabetes, what we label as non-ischemic DCM, is a heterogeneous group. Some of these patients have genetic, some of them probably have inflammatory or infiltrative, some post-cardiac injury, chemotherapy. A lot of different etiologies are clumped into one umbrella term of non-ischemic dilated cardiomyopathy. So obviously the SCD risk varies significantly. Some of these patients may have extremely low risk to extremely high risk. Now, once these inflammatory, infiltrative, and other causes are ruled out, idiopathic dilated cardiomyopathy, the so-called idiopathic dilated cardiomyopathy, probably has better prognosis with contemporary therapy. And also the trials that were done before the availability of contemporary heart failure medications. Most of these patients did not receive beta blockers. Only a small proportion of them received beta blockers, and majority did not receive ACE inhibitors, in fact. And now we know that ARNIs and SGLT2 inhibitors have drastically changed the prognosis of these patients. So if you examine the evidence in non-ischemic cardiomyopathy, the first trial which looked at exclusively non-ischemic cardiomyopathy patients was DEFINITE trial, which was published in 2004. In that trial, the all-cause mortality was not significantly different in ICD group, although it showed trend, but it was not statistically significant. But there was significant decrease in arrhythmic mortality. The companion trial, there was a CRT trial where they had one group of CRTD and the other group CRT pacing, where the CRTD was better than CRTP in terms of overall mortality. Now, SCD heart failure trial was not exclusively NICM, but 50% of the patients were non-ischemic cardiomyopathy, and the benefit in subgroup analysis was between ischemic and non-ischemic was almost same. So, but these trials, as we discussed, were done before the availability of contemporary heart failure medications. Much later trial, that is in 2016, published, Danish study was published, which showed no decrease in all-cause mortality in patients receiving beta blockers, ACE inhibitors, and mineralocorticoid antagonist. But there was decrease in arrhythmic mortality, and also the benefit was seen more in younger patient. So there is a bit of controversy in terms of ICD in non-ischemic cardiomyopathy, but the problem is in a younger patient with a lifetime risk of cardiac failure, sudden cardiac death, if ejection fraction remains less than 35%. The pooled analysis of all this trial, including the Danish study, has shown that there is overall benefit. So especially in a younger patient with ejection fraction less than 35%, it is recommended to put an ICD, and the current guidelines do not differentiate between ischemic and non-ischemic, at least till date, do not differentiate between ischemic and non-ischemic in terms of recommending ICDs. Now, there are two groups of patients who we know a significant proportion are there which do not typically qualify for an ICD, but where the ejection fraction is more than 35%. They're not included in major trials. We have non-sustained VTs, frequent PVC, or unexplained syncope in patients like this. So again, ICDs have not been typically used in this because the trials were not, they did not include these patients with ejection fraction more than 35%. So in these patients, EP studies to demonstrate a sustained arrhythmia is useful. And in patients with non-ischemic cardiomyopathy, again with ejection fraction more than 35%, they were not included in major trials. The evolving technology of CMR, where the presence of late gadolinium enhancement has significantly shown to be associated with arrhythmias. So the presence or absence of LG can help us further risk stratify. And genetic testing, where the specific genes like laminin or phospholamine genes, if they have seen, they definitely confer high risk of death. And even if the ejection fraction of more than 35%, they form an indication for ICD. To summarize, so the ejection fraction remains the single most important criteria for qualifying for an ICD for primary prophylaxis, and of course secondary prophylaxis is straightforward. Yeah, thank you.
Thanks, Dr. Sirish, for being on time. So I think questions will be taken later, Dr. Anna.
Yeah, we think we should we are actually late.
Yeah. Nice presentation.
Yeah, very, very nice presentation, concise, like up to the point, like not many slides. Thank you, Dr. Suresh.
So for the next presentation, can we invite Dr. Raghav Bansal? Cardiac resynchronization therapy, evidence and current guidelines. Dr. Raghav, are you here?
Yeah. Good morning, everybody. And I think my name is being shown wrong. I just corrected. So
We all know.
yeah. So thank you for thank you for inviting me for this talk, and especially special thanks to Dr. Deep and Dr. Deba for this opportunity. So I'll just share my screen and my presentation. So I hope my slides are visible and I'm audible. Hello?
Yes, sir. You're
Yes,
audible.
Dr. Raghav, all good.
Yeah, okay. So we'll start. So I have been given the task to discuss about the cardiac resynchronization therapy, the evidence and the current guidelines. So I'll stick to the basics, and since this is for the students, I'll just try to stick to the basics and not talk about any controversial things. So the bird's eye view to my presentation. So firstly, just to introduce the topic and ventricular dysynchrony. Then we will discuss all the trials, the evidence for CRT use in different population subsets. And lastly, what are the current guidelines, the latest ones. So CRT may improve outcomes in specific subset of heart failure who have, these are the patients who have ventricular dysynchrony, which may improve with the cardiac resynchronization therapy. And as per the current recommendation, CRT is indicated in only 5 to 10% of the patients with total subset of heart failure, including HFpEF and HFrEF. But still, 5 to 10% of the total heart failure population is still a big number, and CRT thus remains a very relevant therapy for us. First transvenous CRT was reported in 1998 by Daubert. So it is a relatively new therapy. It's less than 3 decades old, and all the evidence which has arrived to the table is after that. So what are the clinical consequences of ventricular dysynchrony? So what we are trying to achieve with resynchronization therapy is that we are trying to mitigate the ventricular dysynchrony. How dysynchrony harms? So dysynchrony leads to an abnormal interventricular septal motion, a reduced ejection and the dP by dt of the left ventricle. This leads to reduced stroke volume and reduced ejection. Since the ejection is prolonged, the QRS duration is prolonged, it leads to reduced diastolic filling time. And if there is MR, it prolongs the MR duration and thus the degree of mitral regurgitation also. So these are the all harmful effects of ventricular dysynchrony, which leads to more severe heart failure. And if we look at the prevalence and prognosis of ventricular dysynchrony, so LVBB is more prevalent. And when we talk about it is more prevalent with LV systolic dysfunction as compared to a preserved ejection fraction. And it is even more frequent in patients with moderate to severe heart failure. So what we are looking at is patients with severe heart failure with LVBB and dysynchrony where CRT can help. One of the other peculiar things is that we have a lot of prognostic data which suggests a wide QRS is suggestive of a poorer prognosis with heart failure. And how does CRT benefit in such patients? It helps to maintain synchrony at 3 levels. It improves atrioventricular synchrony. It improves interventricular synchrony between the LV and the RV. And lastly, it also improves the intraventricular synchrony and addresses all the effects of ventricular dysynchrony, which we have discussed before. Coming to the evidence for use of CRT, as cited in the previous talk, that initially the trials are designed for sicker patients, and then we move on towards patients who are less sick. So similar thing happened to CRT patients. So CRT was first tested in patients with NYHA3 and NYHA4 heart failure. Then it was tested in NYHA2 heart failure. And then there were multiple trials which were multiple sub-studies of those trials which showed significant data and formed the current guidelines. So the initial trials which were most important were the MUSTIC, the Miracle, the Companion and the CARE, and the NYHA, NYHA2 and NYHA1 trials were the MADIT CRT, RAFT and REVERSE. So Coming to the first CRT trial, which was back in 2001, the MUSTIC trial. It was a small trial, only 67 patients, out of which only 48 completed the study. So BIV pacing in this trial, it included class 3, class 4 patients with ejection fraction of less than 35% and QRS duration of more than 150 milliseconds. And BIV pacing significantly improved the quality of life and 6-minute walk distance. So the first trial was included sicker patients, and the primary endpoint was only 6-minute walk distance and quality of life. So the next trial was the MIRACLE trial, which reconfirmed the findings of the MUSTIC trial in a randomized control fashion in a larger trial, which was 453 patients, and it was adequately powered to study these outcomes. And here a QRS duration of more than 130 milliseconds was included. And this showed that CRT helps in improving outcomes in such patients. And thus, after 2002, after MIRACLE trial, CRT received a US FDA approval for these subsets of patients. Then came the companion trial and the CARE trial. So these were the first trials which showed mortality benefit with the CRT. So once we knew that in NYHA class 3 and class 4 patients, CRT helps improve quality of life, the next question was, does it improve the mortality? So thus was this trial designed. So again, we needed a larger trial to address the power of the study. So this was a trial of 1,500 patients, and it had 3 arms, OMT, CRTP, and CRTD. And it showed a significant reduction in mortality with CRTP and even more with CRTD arms. And same findings were repeated in the KRHF, reproduced in the KRHF trial, in which, again, it showed a significant mortality and morbidity benefit with the CRT application in NYHA 3, NYHA 4 patients, ejection fraction less than 35%, and QRS duration more than 120 milliseconds. The KRHF trial, importantly, was the first trial to demonstrate reverse remodeling on echocardiography and reduction in MR with CRT. Once we were through that CRT is a therapy can benefit patients with NYHA 3 and NYHA 4, now it was the time to test it in patients with NYHA 1 and NYHA 2 class. So this was the first trial which tested the patients in with NYHA class 2 symptoms or patients with NYHA class 1 who previously had heart failure symptoms. In this trial, QRS duration of more than 120 milliseconds and ejection fraction of less than 40% was included. The primary endpoint was heart failure clinical composite response, which included improved, unchanged, or worsened. And in this trial, it was shown that with the CRT on, less patient had a worsening of heart failure. Thus, it was a positive trial for a CRT response in NYHA 2 and NYHA 1 patients. Importantly, reverse trial also showed that there is significant improvement in echocardiographic indexes with the application of CRT in appropriate patients. Another finding from this study was that in patients with CRT, the response was dependent upon the QRS duration, and more the QRS duration, the better was the response with the CRT. Then came the most important trial of the CRT in 2009, which was the MADIT CRT trial. It was the largest randomized control trial for the CRT, in which included 1,800 odd patients with NYHA 1 or NYHA 2 class and a QRS duration of more than 130 milliseconds and ejection fraction of less than 30%. It had a significant longer follow-up of around 2.4 years, and they studied all-cause death and heart failure as a primary outcome, and they showed significant improvement in heart failure as well as death, mortality outcomes. What was interesting in MADIT CRT was that although in these subgroups where NYHA 1 and NYHA 2, heart failure improved significantly, it may not improve a significant amount of mortality in such patients. So less sicker patients benefit in terms of heart failure, but there may be not much benefit in terms of mortality with application of CRT therapy. Another important thing was that the beneficial effect of CRT was present both in ischemic and non-ischemic subsets with no difference across. Another important observation was, again, QRS duration. So QRS duration of more than 150 milliseconds was a significant predictor of improvement in outcomes. However, less than 150 milliseconds, patient may not benefit that much with CRT. Again, the reproduction of the same findings, that it improves echo parameters. And this was the last important trial, the RAFT trial, again 1,800 odd patients. And it did not include class 1 patients, it included only class 2 and class utilization, which showed significant improvement And importantly, RAFT trial had significant sub-studies to follow, which showed that the improvement is more in patients with QRS duration of more than 150 milliseconds, with a more severe depression in ejection fraction of less than 20%, patients who had left bundle branch block in comparison to IVCD or RBBB, and patients who were in sinus as versus patients who were in atrial flutter or fibrillation. These are all important findings because these are the foundation of the current guidelines, which we are going to discuss in the next few slides. So this was the last trial of CRT, major randomized control trial, which we all need to know. So this was for pacing indication. This was not particularly for heart failure patients, but patients who had a pacing indication with an ejection fraction of less than 50%, and CRT was compared with RV pacing. Here the ejection fraction criteria was not 35%, but 50%, and it was shown that CRT is superior to RV pacing in such patients. When we talk about CRT response, so it can be of clinical response or echocardiographic response, hospitalization, improvement in NYHA class or quality of life, improvement in 6-minute walk distance or reduction in diuretic dose, while the echocardiographic response is in terms of improvement or stability in ejection fraction, reduction in LV size or increase in stroke volume, and reduction in mitral regurgitation grade. So the last part of my talk, the current guidelines. So these are the latest 2023 Heart Rhythm Society guidelines on cardiac physiological pacing. So physiological pacing is a new term. It includes both CRT as well as the conduction system pacing. So these are the latest guidelines to discuss, and these guidelines consider the previous recommendations from the 2018 ACC-AHA guidelines as well as the recommendation from the 2021 ESC guidelines. So as per these guidelines, so when we consider CRT for CHF in patients in left bundle branch block, so for the students, if they find it hard to remember, so what they can remember is, so sicker patients, lesser ejection fraction and more QRS duration and LBBB. So these 4 criteria, when all are there, so it becomes class 1. So LBBB is there, ejection fraction less than 35%, QRS duration of more than 150 millisecond, and NYHA class of 2 to 4. CRT is indicated as a class 1 indication. Remove anything out of it, remove the QRS duration, make it 120 to 150, it becomes class 2A. If you bring the NYHA class down to class 1, it becomes class 2B. And if we talk about the female sex in such patients, so it has been found in the subgroup analysis that female sex may specifically benefit more with the CRT. So it may still be considered as a class 1 with patients who have 120 to 150 milliseconds, LBBB, ejection fraction less than 35, and NYHA 2 to 4. When we talk about patients with 36 to 50%, so this is the subgroup for heart failure indication. This has not been prospectively tested over randomized controlled trials. And in these subset of patients, CRT or his bundle pacing may be tried in select scenarios, but it remains class 2B and should not be routinely used. For patients with non-LBBB, so with patients with LBBB, ejection fraction less than 35%, more than 150 millisecond duration, we had class 1. So now if we remove LBBB, there is no class 1. Now for non-LBBB indication, everything is class 2B or 2A. So when we talk about non-LBBB, more than 150 milliseconds and ejection fraction of less than 35%. So if the NYHA class is more, 3 or 4. So every other thing is there, worse NYHA class, more QRS duration, less EF, and only one thing is missing is LBBB, it becomes class 2A. Now NYHA class drops down to 2, then it becomes class 2B. Now, if the QRS duration drops down and it is 120 to 150, it again becomes class 2B. And there is no benefit in patients with NYHA 1 or 2 with a duration of less than 150 or a duration of less than 120. For patients with pacing-induced cardiomyopathy from the block HF trial, since CRT is better than RV pacing, even if the EF is less than 50%, so CRT is a class 1 indication for patients with PICM with high right ventricular pacing burden. So this is for patients who require upfront pacing. So very simple. If the patient has an ejection fraction, patient who requires pacing with a anticipated substantial ventricular pacing burden, EF of 36 to 50%, CRT is class 2A. EF more than 50%, it is only 2B. if the EF is more than 35% and the pacing is not much required, then we may just do with an RV lead with minimization of RV pacing. So lastly, when we talk about patients with atrial fibrillation, so these are the patients who may not respond that well, as noted as in the sub-study of the RAFT trial, because as the rate in the atrial fibrillation increases, there is decrease in the significant pacing, BIV pacing, which leads to increase in the non-responder rate. So thus, AF patients need a special mention, and even when a patient is in AF with controlled ventricular rate and meet all other CRT implant criteria of ejection fraction of less than 35%, LBBB, QRS duration of more than 150 millisecond, still CRT remains a class 2A indication. And if patients have an uncontrolled heart rate, then they should be considered for an AV junctional ablation, especially if the BIV pacing is less than 90% after a CRT. This is the last slide. So when just to compare CRT-P versus CRT-D, so there are no clear-cut guidelines on this. However, it should be done on a case-to-case basis in a clinical scenario. So the factors which favor the CRT-P implantation include non-ischemic cardiomyopathy, as discussed in the previous talk, especially without in the absence of a myocardial scar on the cardiac MRI. Patients who are very sick and have a shorter life expectancy, like old patients, patients with major comorbidities like cancers, or very obese patients, or very frail patients, or a very poor renal function. So these are the patients who are where the implantation of the device is being done for the improvement in quality of life and improvement in heart failure rather than prevention of sudden cardiac death. Here we can avoid CRTD and implant just a CRTP. However, this has to be done on a case-to-case based scenario. There is no clear-cut guideline on this. So to summarize my talk, important points to remember for the students, that the important NYHA class 3 and class 4 trials are the Miracle, Companion and CARE-HF trial. The Companion and CARE-HF trial showed mortality benefit, while Miracle just showed improvement in quality of life. Amongst the NYHA class 1 and class 2 trial, we have the reverse, MADIT and RAFT trials, which all showed mortality benefit. Stronger evidence for higher NYHA class, lesser EF, QRS duration of more than 150 millisecond, and typical notched LBBB. If all these features are present, it is a class 1 indication. If you remove one feature, it becomes class 2A. If you remove two features, it becomes class 2B. CRT to be considered for pacing indication in patient with reduced EF. It is less effective for AF, and CRTP versus CRTD in a clinical decision on a case-to-case basis. Thank you. I'll be happy to take any doubts if anybody has.
Thank you, Raghav, for a concise talk. And I think in interest of time, we will move on to our next talk, which is on by Dr. Adhikari on antiarrhythmic drug. I would like to invite Dr. Adhikari.
Yeah. Am I audible?
Yeah, you are loud and clear.
Okay, I'll share my screen. So are my slides visible?
No, not yet. Yes,
Is it
yes.
visible?
Now we can. Yes, yes.
Okay. Good morning, everyone. Thank you to IHRS for allowing me this platform to present this thing for DM and DNB residents. So my scope of discussion will be today on antiarrhythmic drugs, basically their classifications, the updated classification, and some of the newer drugs. And if time permits, I will go through the salient points of each of the antiarrhythmics that are in use. So arrhythmias, as we know, are cause or result of a wide range of cardiac issues, and they can have a lot of morbidity and mortality, and important cause of sudden cardiac death. And among the different management strategies, pharmacotherapy using antiarrhythmic medications is definitely most important and mostly used. And despite the conventional classification that was done historically, newer schemes have been attempted and they are still ongoing. So we'll just get a brief overview. So mechanism, we have a brief overview. It can be either due to abnormal impulse generation or abnormal impulse conduction. It can be autonomic rhythms or triggered rhythms. Among the impulse conduction can be re-entry or conduction block. And this is very important slide to know the fast response action potential and slow response action potential, which has already been discussed, but still just a brief overview. The fast response action potentials is seen in cardiac myocytes and His-Purkinje systems, where we have a phase 0, which is caused due to opening of the voltage-gated sodium channels. Phase 1 due to the transient outward flow of the potassiums. Phase 2, that is the plateau phase, due to the L type of voltage calcium channels opening, and ultimately the phase 3, that is caused due to the efflux of potassium channels. And in case of slow response action potentials in sinus node and AV node, there is a phase 0 phase or phase 4 phase, that is called a diastolic depolarization, that is caused due to slow influx of sodium channels, and the phase 0 phase is caused due to rapid influx of calcium. So this two action potentials are important because the different drugs act on different of these phases, specifically the phase 0 of fast action potentials and phase 3 of the fast action potentials, and the phase 4 of the slow response action potentials. So the classification, the initial classification that was done in 1969 by Dr. Miles Vaughan Williams, who was a British pharmacologist, and his postdoctoral student, Dr. Brahman Singh. They proposed a simple 4-class system that takes into account the primary EP properties of the drug. So issue was that the most of the antiarrhythmic drugs, they have either sodium, potassium, or multiple channel properties. They can have a primary drug effect, and they have a multiple other channel effects. So and they also have some primary autonomic effects, and they have pro-arrhythmic effects because of all these multiple actions. So the first simplified classification was based on the primary action of the drugs. So this classified the antiarrhythmics into 4 classes. Class 1, which were the sodium channel blockade, specifically which used to act on the phase 0 of the fast action potentials. Class 2, which were the beta receptor blockers, which acted on the slow action potentials by a mechanism suppressing the activity of the autonomic tone mediated by adrenergic and non-adrenergic response. And class 3 were the potassium channel blockade, which used to act on the phase 3 of the fast action potential. And finally was the calcium channel blockade, that was class 4, that also acted on the slow action potential. So the advantage of this system was it was very simple and easy to understand. Further, it got classified into 1A, B, C, which we'll discuss. Disadvantages was that though a drug had more than one class of action, it did not take into account. And there were a few drugs which did not fall into any of the categories. Later on, they were added as class 5 drugs like adenosine or digoxin. And the indication of their use were not very clear from this. But it was relatively simple, and it is still now mostly employed for teaching, for learning everywhere. And add-ons have been added to this system, which have further been modified. So to address this limitations of this system, in 1991, task force by European Society of Cardiology met in Sicily. So they proposed a system called Sicilian Gambit. Basically, a gambit is like a queen's gambit, a move in chess, which is very aggressive, takes into account a lot of moves by the opponent. So this classification also, they further complicated the matter, and they reclassified the drugs according to their highest channel action, moderate channel action, low channel action, effects on ECG, and effects on other parameters. It was more reflective of the drug effect on physiology. However, it compromised on the simplicity, and it is very difficult to remember like that. But it had some of its implication. So we will basically discuss the Vaughan Williams, and on top of that, the modifications that were made after all these discussions. So in the class 1 drug, basically we have class 1A, class 1B, and class 1C. So they are all sodium channel blockers. They have some differences. So class 1A has a moderate sodium blocking effect, and it inactivates the sodium blockade in the open state. Class 2 has a weak sodium blocking effect, and class 1C has the strongest sodium blocking effect. So this, if you see in the fast action potentials, the phase 0 phase, the class 1A usually leads to slowing down of the depolarization. Class 1B has got the little lesser effect on the phase 0 of the action potential, while class 1C, that is like flecainide and propafenone, they have the steepest action on the phase 0 phase of the fast action potentials. In addition to that, these classes had other effects also. One is the potassium channel blockade. So the class 1A has the moderate potassium channel blockade effect, which results in increase in the effective refractory period of the action potential and leads to increase in the action potential duration. Most significant ECG finding is QT prolongation, whereas 1B has got no effects on potassium channel, while 1C has got some minimal effect along with some mild beta blocking activity of propafenol. So these effects have to be taken into account whenever we are prescribing drugs for specific conditions. So if we compare 1A, 1B, and 1C, we can see that 1C has got the steepest action on the phase 0, while 1A has the second most, and the 1B has the least action, whereas the prolongation of the action potential, which leads to QT prolongation, is most in the class 1A. Among the class 2, 3, and 4, so 2 and 4 both acts on the sinus node and AV node, that is the slow action potential. So they don't have actions on the ventricular or atrial myocytes as such. So class 2 causes depolarization slowing in the pacemaker cells as well as the AV node, which leads to slowing down of the sinus rate and prolongs the PR interval. Whereas class 4 also has a similar effect on the ECG and action potential. Class 3 has got a multitude of drugs which have got actions. Except potassium, they have got multiple other actions, and they are either selective or non-selective. Their main action is delaying the phase 3 of the fast action potential, which leads to prolonged ERP and prolongation of the QT interval. So class 1A and class 3 should be known like they are most prone to cause QT prolongation. So after this, in 2018, at the centenary birth anniversary of Vaughan Williams, Circulation published this study, which took into account the initial Vaughan Williams classification, and they included some other classes and changed the classes of some of the drugs to include the current and potential antiarrhythmic agents that could be further discovered. And they expanded the current classification model. So they included class 0 also, which included evabredin that acts on cardiac automaticity on the sinus node, that is on the slow action potential of the sinus node. Basically, it is a funny channel blocker, funny sodium channel blocker that acts on the diastolic depolarization phase, and it is used in inappropriate sinus tachycardia, stable angina, and heart failure also. And I'll just discuss the salient points regarding this. So evabredin was also included. Among the class 1, it included, apart from class 1A, 1B, and 1C, it included class 1D, that is ranolazine. As we all know, ranolazine is an anti-anginal drug which acts by late sodium current blockade. And there have been potential use found in long QT3 syndrome, that is mediated by SCN5A mutation, as well as in VT and AF, where experimental trials are going on. So they also included this in the class 1D. So it has got, it is metabolized by CYP3A4, and it has got a mild QT prolongation also due to the delayed rectifier potassium blocking, but still it is found to be useful in long QT3, though it is not recommended, but still experimental studies are going on. Then coming to class 2. So class 2 usually includes the beta blockers that they have made it into class 2A. So class 2, they have reclassified as autonomic inhibitors and activators rather than just beta blockers. So this basically encompasses all the channels that mediate their action through the G protein mediated, cyclic AMP mediated, phosphokinase mediated, ultimately calcium channel mediated action. So the class 2A includes the beta blockers, that is the non-selective and the selective ones. Class 2B, they have included beta agonists, that is isoprenaline or isoproterenol. That is also used in refractory VT by Brugada syndrome, or in case of long QT mediated torsades also. So isoprenaline has also been included in that. And it has also included muscarinic receptor inhibitors, that is cholinergic mediated, and muscarinic receptor activators like atropine, hyoscine, scopolamine. Usually we'll use it in supra-ECN AV blocks. And 2D includes muscarinic receptor activators. That has included digoxin, so which is used in AF with fast ventricular rate to control the rate, as well as other purposes. So this has a like encompasses a lot of other medications, and it has also included adenosine into class 2E, because adenosine basically mediates by adenosine A1 receptor and then causes AV block mediated by cyclic AMP mediated procedures. So all these have been clubbed together in the updated classification as class 2. Then coming to class 3. So class 3 includes the non-selective potassium channel blockers, that is amiodarone, dronedarone, and other drugs. And it includes like selective HREG, that is a rapid IKR blockers like dofetilide, ibutilide, sotalol. Those are all included previously. It also adds vernaculant, that is a multi-ion channel blocker, which acts through ultra-rapid potassium current channel, and its selective action of atrial effective refractory potential effective refractory period prolongation is used for immediate conversion of paroxysmal AF to sinus rhythm. So it is not very popular or not used in India, but IV preparations are available elsewhere. And it has also included some anti-anginals like nicorandil, that is potassium channel openers into it. And it has also included pinacidil, which is an experimental antihypertensive drug. So all potassium channel agents have been included in this updated classification into class 3. Then class 4, apart from the typical verapamil and diltiazem, which are late type of calcium current channel blockers, which are used routinely, it has also included flecainide and propafenol, which were in class 1C as class 4B, because they also have some effect on intracellular calcium effect by ryanodine calcium blockers. So this effect is utilized in VT mediated by VT mediated in catecholaminergic CPVT. So this has also been included in class 4B. And it has also included some of the experimental drugs that act via sarcoplasmic calcium ATP activator, that is SERCA pump activators, some of the surface membrane ion exchange inhibitors, that is like SLC81, and phosphokinase and phosphorylase inhibitors. These are all experimental drugs which have not yet been named or not yet been clinical practice, but they have been taken into account in the updated classification in the class 4. And they have additionally given class 5 to 7 also. Class 5 is basically mechanosensitive channel blockers. These are also experimental that mediate their effect through intracellular calcium signaling. And calcium channel gap junction blockers, that is electrical coupling between the cells can be blocked. These are also not yet come into practice, but these are in trials and in clinical trials. Apart from that, this system also encompasses upstream regulators that change the electrophysiological properties by structural modifications. Those are used in heart failures like ACE inhibitors, ARBs, omega-3 fatty acids, statins in case of coronary artery disease. So all these have also electrophysiological role in preventing arrhythmias. So all these have also been taken into account into this updated classification. So it is a very complex classification, which includes the initial von Williams classification as well as the additional drugs which have been found to have antiarrhythmic effects or experimental drugs as well. So I'll just mention a few points about the specific drugs. You can just take a note of this if there is some question regarding that. Some salient points only. So quinidine is a class 1 drug which causes which is used.
Dr. Adhikari, you can rush through these slides.
Yes,
I think.
so it causes synchronism and it causes digoxin toxicity and is used in Brugada and idiopathic VF treatment. Then procainamide, it is not very popularly used yet. We should know like patients who are slow acetylators can cause lupus. It can cause lupus. Disopyramide is another 1A class, which is second line drug. It has got the most potent anticholinergic effects that is contraindicated in prostatomegaly because it causes urine retention, and contraindicated is heart failure as well. Morphine and ajmalin are like not used very popularly. So all 1A drugs have potential to cause QT prolongation and torsades. Among 1B, apart from lignocaine, which we used in case of refractory VT, mixilitin is a popular drug that is used in second line in ventricular arrhythmias. Specifically, 1B drugs act only on ventricular myocardium, not on any other things. So they are most important in post-infarction ventricular arrhythmias. Important to know that they have got neurological side effects like tremor, myotonia, etc. Among 1C, which are the most potent sodium blockers, propafenone and flecainide, they are used as pill-in pocket for AF, for fast conversion from AF to sinus rhythm. And it has been found that flecainide increases mortality in patients with structural heart disease like MI. So it is not used to be used in structural defect heart like low LV function. And it is also used as flecainide challenge test in Brugada syndrome. Amiodarone is the most commonly used. We should know that it is the longest acting class 3 or broad spectrum antiarrhythmic which has got multiple channel properties. Its IV injection is frequently causing hypotension due to its co-solvent like polysorbate, and benzyl alcohol. Oral formulations usually does not cause so. And one of the things you should remember, like most of the class 3 drugs, they act maximum at slower heart rates, which is called reverse use dependence. Amiodarone does not have this effect, so it is less prone to cause QT prolongation rather than other medications like sotalol or dronador or dofetilide and ibutilide. So dronedarone is basically a non-iodinated amiodarone, which causes less of the thyroid adverse effects. So we know amiodarone has got multiple adverse effects. Most prominent is the pulmonary fibrosis, which should stop. And thyroid hyper side effects is caused less due to dronedarone. And it is contraindicated in heart failure, has been found to have more mortality. Sotalol is a beta blocker with a prominent class 3 action, and it causes prolongation of QT due to action potential duration prolongation. So it should be contraindicated in long QT intervals. Other 3 class 3 drugs are dofetilide, which is upcoming. It acts selectively on rapid delayed rectifier potassium channels and does not affect on other channels. Its IV counterpart is ibutilide, which is used for pharmacological conversion of atrial flutter to sinus rhythm or atrial fibrillation to sinus rhythm. Bretylium was withdrawn. It was causing a lot of postural hypertension, is not used as much. Among class 4, we are using verapamil and diltiazem. They have got more effect on delayed after polarizations of Purkinje fibers. So used in posterior fascicular VT and idiopathic VT, apart from supraventricular tachycardia and apart from other supraventricular tachycardias. Verapamil is known to cause reflex sympathetic stimulation, which counteracts its direct bradycardia role. And diltiazem causes less of this hypotension myocardial depression. So it can be considered even with little bit of heart failure or little bit dysfunction. Verapamil usually we should not prescribe in such patients. Adenosine, we all know it is a short-acting class 5, which is now considered as class 2 action, and it is used for termination of node-dependent supraventricular tachycardia. Its most important use is to be used properly, that it should be injected in a large vein like antecubital vein on a right side of the right hand, right upper limb, and with a bolus of fluid after that. So that acts on termination of supraventricular tachycardias. It is also used in coronary artery disease as FFR.
Thank you, Dr. Adhikari.
Yeah,
For
I
it.
got disconnected. Yeah.
Yeah,
So
sorry, no issue.
I finished almost everything. Almost the newer drugs, I'll just mention the names. So among the newer drugs, ertapenemil is a intranasal calcium channel blocker that is under experiment for termination of supraventricular tachycardia. And there are a lot of other drugs which are still in experimental stages, acting on different novel cardiac channels. And there are some drugs which have different active actions and different uses, which are reused in antiarrhythmic potentials like doxapram, which is a respiratory stimulant which acts on potassium channels. Canakinumab, it is a IL-1 beta antibody that is, and colchicine and botulinum toxin that are all used in like experimental studies in AF. So all these are the new drugs that are coming up, and all the drugs, they have to be safety profiled. They should be seen on action on different channels, whether upstream therapy is there in preventing cardiac remodeling, repurposing of older drugs. Risk factor management is also important, especially in AF. There are some novel formulation for administrations, and proper design of the newer drugs is needed. So this is my take-home message. Basically, Vaughan Williams classification is the simplified classification, which addresses the primary EP effect of the drug. There are some pro-arrhythmic risks which necessitate proper prescribing of drugs in different scenarios. Modernized mechanisms of classification retain the original classification and add additional classes taking into account the newer drugs. And there is still ongoing research on newer antiarrhythmics that are still being developed. Thank you.
Yeah, thanks, Dr. Adhikari. That was a difficult job assigned to you with this new classification, but yes, it has made some inroads. So, next speaker, I would like to invite Dr. Anindya Ghosh for recent developments on mainly on conduction system pacing, leadless pacemakers, and subcutaneous ICD. Dr. Anindya Ghosh.
Good afternoon.
Yeah, just a second, Dr. Anindya. Just give me 30 seconds here. Yes, this is a very important topic coming up, the recent developments condition, because every exam paper will have at least you can expect one of these questions to come up to you. I think the audience will hear to this in depth and take notes from this. So before we go to the last topic, I think it's my duty here at this point of time to thank Sun Pharmaceuticals, who have been hosting this webinar to their MedGami platform. Dr. Roshni, who is hosting this webinar. A big thanks to you, Dr. Roshni, for creating the registration link and having the registration. We had at least 250 plus registrations for this webinar, and to keep this registration rolling on time and all, and preparing everything and hosting this webinar as well. Thank you, Sun Pharmaceuticals. And then, of course, the next webinar for these students will be scheduled on February 9th, which is a Sunday. And then, again, a heartfelt thanks to our society president, Dr. Ajay Nayak, Dr. Rakesh Yadav, Dr. Anup Gupta, and all our colleagues to keep this program running successfully. So handing over to you, Dr. Anindya, please carry on this very important topic.
Thank you so much, sir. At the outset, I would like to express my sincere thanks for having given this opportunity to present such an important topic on this prestigious forum. I'll straight go on to the topic. It's like there are three topics which we have to discuss: the recent developments in the field of pacing. First, we'll discuss the topics under the following headings: what are they? Why are they required? What is the evidence? What are the indications? And what are the possible complications and limitations of those technologies? First is conduction system pacing, as the name implies. What is it? It is pacing of different components of the conduction system. I'll be as detailed as possible without consuming more time. So different components of the conduction system, we know there is a rough idea in everyone's mind. It starts with the SA node, then internodal pathways. There is the Bachmann's bundle, then AV node, his bundle, and bundle branches. Accordingly, the conduction system pacing includes all of them. In the atrial channel, there is Bachmann bundle pacing, which results in a narrow paced P wave, and then there is a ventricular conduction system pacing, which includes his bundle and both the bundle branches, right bundle pacing, which is recently come up, and also left bundle branch pacing, which includes left bundle pacing and left fascicular pacing, both of which will result in a narrow paced QRS. And why is it required? We have seen in the past from major randomized studies that there is no difference from single chamber and dual chamber pacing, but with every 1% increase in ventricular pacing, this is a very important point for our DNB residents. Every 1% increase in ventricular pacing increases the risk of heart failure hospitalization because of a subsequent heart failure or any long-term complication by 5%. So there is also a detrimental effect of right ventricular stimulation, as was seen in the very, very important David study. In David study, there were no patients who needed a pacing indication. They just took patients with an ICD indication, and they randomized it to a DDR pacing at 70 beats per minute versus a backup ventricular pacing. They found that with the DDR rate responsive pacing, there was a significant risk of harm requiring heart failure hospitalizations and significant morbidity, and it was stopped because of this observation. So in short, there are acute and chronic effects of right ventricular pacing which are detrimental. It causes electrical dyssynchrony, drop in left ventricular ejection fraction in up to 10 to 20% of patients. There is a drop in ejection cardiac output and increase in filling pressures, adverse remodeling, chamber enlargement, fibrosis, ultimately resulting in atrial fibrillation, tricuspid valve regurgitation, all of which result in the risk of pacing-induced cardiomyopathy. This is a simple slide which indicates if the patient needs chronic RV pacing, they will develop mechanical dyssynchrony as well as electrical dyssynchrony, which will result into more vulnerable substrate being male sex, wider paced QRS. If the native QRS is wider, then also it increases the risk of pacing-induced cardiomyopathy. So greater the pacing percentage, greater the risk of pacing-induced cardiomyopathy, which is up to the tune of 10 to 20%. Now, in this pacing-induced cardiomyopathy comes the role of conduction system pacing, and also we'll discuss extended roles also. Previously, biventricular pacing was used to mitigate this problem, but now with physiological pacing, electrical synchrony is better, and there is possibility of reversal of pacing-induced cardiomyopathy to the tune of around 70 to 90%. So what is conduction system pacing? Basically, we will not discuss Bachmann bundle pacing and his bundle pacing. We'll just focus on left bundle area pacing. So conduction system pacing is actually, we know there are diseases of the conduction system which will lead to bradycardia. So there is a block somewhere in the conduction system. Now, what our conduction system pacing does is actually bypass that block, and it is similar to a coronary artery bypass surgery where there is a graft which is placed in the artery distal to the block. So just have to pace the lead, position the lead distal to the block, and we will be able to achieve conduction which is as normal, as physiological as in a normal heart. So these are the modes of endocardial pacing. I will discuss only his bundle and left bundle area. So this is just a simplified diagram. A normal conduction system will conduct fast to the His-Purkinje system, then slowly through the myocardium. On the other hand, RV pacing is actually a muscle-to-muscle conduction simultaneously. Late on, it will capture the conduction system. His bundle pacing is most physiological. It will capture the conduction system at the most proximal region of the ventricle. It will spread synchronously at the same time to the both ventricles, resulting in a narrow QRS. Right left bundle branch area pacing, on the other hand, is targeted towards a left bundle, and hence it will result in a incomplete RBBB. So that is the difference between the paced morphologies. You can see on the right side, on the left side, RV apical pacing will lead to a wider QRS, non-physiological activation. His bundle pacing will be as normal as a physiological pacing, and left bundle area pacing with the introduction of an incomplete RBBB will also result in near normal physiologic activation. So there are some criteria for his bundle area pacing. We'll just look briefly into it. So there is selective and non-selective. What does selective mean? Selective means we are capturing only the conduction system, and when non-selective, we say it is capture of the conduction system plus the local myocardium. It is such a small target that we invariably end up having non-selective capture only. But how to differentiate on the ECG? Both the ECGs will be demonstrating a narrow QRS. However, the paced QRS duration will be equal to the intrinsic QRS duration in case of a selective capture, because there is no myocardium nearby. There will not be a delta. There will be a isoelectric interval because only conduction system is getting captured, and the stem to QRS will be equal to the HV interval. The site where we are pacing, it will take the road through the bundle branches and activate the ventricular myocardium. On the other hand, non-selective means there is capture of the local myocardium. Hence, there will always be a minute prolongation of the QRS duration compared to the intrinsic, and stem to QRS will be less than the HV interval, and there will always be a delta because the ventricular activation begins from the local myocardium. Similarly, criteria for left bundle branch area pacing, it's very difficult to remember. You have to just keep in mind that there will be an incomplete RBBV, QR, monophasic R, RS, or even a big Q and small r in V1. That is the criteria in all of them. When we discuss conduction system pacing, we include only the selective and non-selective captures and not LV septal pacing. How do you differentiate that? The left ventricular activation time will not go into the details. Just you have to remember the numbers. If it is less than 70 to 80, it is a conduction system capture in the left bundle branch area. Also, if there is a change in morphology on decremental output pacing, it's a conduction system capture. So in short, incomplete RVBB, LVAT, which is shorter, less than 70 to 80, and there is a change in morphology in decremental output, defines left bundle branch pacing and not LV septal pacing. LV septal pacing, on the other hand, which is not included in conduction system pacing, is the same essentially, with the exception that the left ventricular activation time will be a little longer and there will be no change in morphology in decremental output pacing. There are different catheters. You don't really need to remember their names or stuff, because previously there was only one vendor. Now there are 4 vendors. You just need to understand there are 2 curves. There is a primary curve and then there is a secondary curve for helping us reach the ventricular septum. And with and the results with all of them are near equal. So left bundle branch area pacing, when we start from the left side of the LV myocardium, so RV septal myocardium, and we go towards the left bundle. As we penetrate the septum, you will see this is a V1. It will result in an incomplete RVBB. So what is the evidence of conduction system pacing? There has been a lot of data. There is a definite benefit of his bundle pacing compared to RV apical pacing in the follow-up of up to 4 years, with reduction in the need for heart failure, hospitalization, death, or upgradation to a BIV. So this is a very important paper. Similar evidence has shown significance compared to left bundle versus RV apical. So there is evidence supporting a superiority of left bundle or his bundle compared to RV apical pacing. However, there is no difference between selective and non-selective. We discussed just now, non-selective is conduction system plus little bit of the surrounding myocardium. So there's no difference when we do a selective or non-selective conduction system pacing. Also, in terms of his bundle pacing, left bundle area pacing, there are no significant clinical outcomes. However, there is some procedural difficulties in his bundle pacing versus left bundle area pacing. We'll discuss that also. So there are several trials because it achieves physiological resynchronization. It has been the conduction system pacing has been compared with biventricular pacing in several randomized trials, and all have shown non-inferiority or even superiority in the recent ones. So what else is there in conduction system pacing? It can help in reversing pacing-induced cardiomyopathy. It can help in achieving physiological resynchronization in a normal heart. Plus, it can be used to fortify ICD therapy as well, also CRTD as well. So, which is called a hot or lot ICD or a hot or lot CRTD. It is possible because we know left bundle branch block is a patient with a wider QRS duration is an indication for of CRT, as we just discussed. But in them also, it's possible to correct the bundle branch block with a his bundle or even left bundle pacing, because majority of patients, if you take 100 patients of left bundle branch block, majority of them will have block proximal in the conduction system. So almost half of the patients will have block at the level of his bundle. That is because there is a longitudinal dissociation of fibers in the his bundle, and the subsequent left bundle proximal lesions will cause up to 66% of level of lesions in case of a left bundle branch block. So what are the indications? The only we have to remember, there is no class 1 indication for a left bundle area pacing or a conduction system pacing. Only approved indication is as an alternative to BiV pacing for cardiac resynchronization. All are class 2, whether it's class 2A or 2B, we'll just discuss now. So conduction system pacing got into the guidelines first time in 2019. It was a class 1C initially as a pace and update strategy, but currently it's 2B. In last 2021 EC guidelines, there is an AV block, more substantial ventricular pacing, and EF more than 40%. It's a class 2B recommendation. It can also be used as a failed in cases of failed CRT implantation with a backup lead. The current guidelines, as Dr. Raghav Bansal also was discussing, is the 2023 IHRS APHRS LHRS guidelines on cardiac physiologic pacing. So there are patients who are CRT candidates. There are patients who are not CRT candidates. Classically, non-CRT candidates are the ones who have an EF more than 35%. So in patients with more than 35%, this entire table is based on is for patients who have more than 35% EF. If there is substantial ventricular pacing, substantial ventricular pacing means any patient where you think the pacing percentage will be more than 40%. So intermittent AV block, second degree AV block, Thymovids type 2 block, or complete heart block, all are candidates for a conduction system pacing, but only in a class 2A or class 2B category. If there is substantial ventricular pacing, there is always if the EF is on the lower side, 35 to 50, 36 to 50, then it's a class 2 indication. However, if it's more than 50, it becomes class 2B. Similarly, if there is a substantial ventricular pacing is not required, then also if there is an LBBB, it becomes a class 2B indication. So if there is a substantial ventricular pacing requirement, then with a lower EF, 36 to 50, you consider it's a class 2A. However, if the pacing percentage is less than what is substantial ventricular pacing, any EF, irrespective of EF, if there is no need for a substantial ventricular pacing, you consider it to be a class 2B. Now we discussed what are the indications, what is the place of conduction system pacing in CRT non-eligible candidates. So EF was more than 35. What about patients who are less than 35? So CRT remains the class 1 indication if there is a patient with a low EF, sinus rhythm, LBBB with a wider QRS with class 2, 3 or 4 symptoms on GDMT. CRT stays as the class 1 indication, and left bundle conduction system pacing, whether it's his bundle or left bundle branch area pacing, is only a class 2A as a bailout for BiV pacing. So as I told, it's a class 2 indication when there is a bailout. Also in patients who have who even you can consider even the conduction system pacing as an alternative to BiV pacing, but that becomes class 2B. So only stronger evidence is as a bailout, and a weaker evidence is as a alternative to CRT pacing. So CRT indications class 2A if CRT fails, otherwise it's class 2B. Then there are patients who are CRT candidates but not non-LBBP. Where is the place? The place is still CRT BiV pacing is the class 2A indication, and cardiac physiologic pacing, which is the conduction system pacing, only figures as class 2B. So in a patient who needs CRT, you can use conduction system pacing as a bailout for class 2A or as an alternative as in class 2B. In patients who have less than 150 milliseconds and still need CRT, it is not well established. So the thing is class 2B. On the other hand, we discussed before in the flow chart, if there is a mid-range ejection fraction, at best 36 to 50% with requirement of a significant ventricular pacing, then it is reasonable, but only to prevent the risk of a pacing-induced cardiomyopathy. So with mid-range EF, with less pacing, as we discussed, less than substantial ventricular pacing, it's all 2B, because class 2A is occupied by the traditional RV lead placement still. However, if there is a patient who has a pacing-induced cardiomyopathy clinically, then you can use it as a class 2A indication after as an alternative to CRT. So CRT still remains the class 1 indication. So patients with, we had seen initially ESC 2021 guidelines making it a class 1A for a pace and upgrade strategy, but these days it is all a class 2B indication as an alternative to CRT. With this, we'll discuss the limitations. There are limitations with his bundle because the target is small. There is advantages to left bundle area pacing because it's larger target. Their thresholds are better, sensing is better. That is because his bundle is a very small target and it is surrounded by a fibrous tissue, and that leads to a poor sensing and pacing parameters. There is more expertise which is required in his bundle pacing. There is less of a learning curve for left bundle area pacing. Backup ventricular leads may be required for his bundle, where there is it is not required for left bundle area pacing. Long-term extractability, because leads are deep into the septum, it is often difficult. Although extractability has been demonstrated in recent studies, it is deemed difficult on, and it may cause some local injury when you consider extractability for left bundle area pacing, whereas it is very easy to extract his bundle leads. So the main limitation is very long-term data is still pending, no mortality benefit yet for cardiomyopathy patients, and feasibility of extraction has to be demonstrated. Now we'll discuss.
Dr. Anindya, I think we are way ahead of time, so you should wrap it fast.
Yes. So leadless pacemaker, why is it required? Because all complications of pacemakers, traditional pacemakers, are pocket related or lead related, and thereby we need reduced invasiveness, improve efficiency, and therefore we have leadless pacemakers. Leadless pacemakers are just smaller than the AAA batteries which we use in our day-to-day lives. There are two kinds of leadless pacemakers: one with tines, one with screw. The one with tine is smaller, hence it's called Micra. It's the Medtronic product. On the other hand, there is a lead with the tine, which is from Abbott, which is called Avier. So there are two leadless pacemakers currently in market, Micra and Avier. We'll discuss briefly. Avier is as we discussed, Micra has a smaller profile. It's 25.9 millimeters, less heavy and smaller profile. Both will go through a same introducer sheath. The battery, because Micra is a smaller device, has less battery capacity. Longevity will be lesser, but in short, Avier will have a active screwing mechanism, has a larger profile, and it has been shown to be retrievable also. So what is the evidence? We know from various trials that if you do the leadless pacemaker will take out the long-term complications of transvenous, which is related to pocket and leads. So there is a 56% relative risk reduction. Also, it has been shown that AV synchrony is possible with Micra AV pacemakers, which have a accelerometer derived algorithm which will detect atrial activity and it will pace the ventricle. So what are the indications? Indications are most important for leadless pacemakers. You cannot just implant a leadless pacemaker in a patient if he just says, I want a leadless pacemaker. It is an alternative to transvenous pacemakers when there is no vascular access, or if there is a high risk of infection. The high risk of infections are particularly patients who are on dialysis. So if it can also be used as an alternative to single lead ventricular pacing if the life expectancy is very less. You can consider in nonagenarians or octogenarians. So this is how a normal leadless pacemaker is implanted. It involves a capsule. It goes through a sheath, 27 French for both, and it will go into the ventricle. In the apical septum, it will be implanted. There are two mechanisms, tined, and then there are screwing mechanisms. So it is, the indication is classically for a patient like this who has bilateral vascular access occlusion, and in them it is, if they don't have a history of heart failure, you can implant a micra. So currently, the newest innovation is there are we just saw AV synchrony is possible, but atrial pacing was not previously possible. It is now possible only with the AVR pacemakers, which include an atrial leadless pacemaker. So you can put a leadless pacemaker in the atria as well, and you can achieve DDD pacing as well. So there are complications, cardiac perforation, tamponade, although in very small numbers. So what is subcutaneous ICD? It is also a very important topic because it has been there for the longest time compared to the other recent developments. It involves, because it's a subcutaneous, the name itself says it is the pulse generator, and all the components of the ICD are placed in the subcutaneous area. So there is a pulse generator which is placed in the axilla, and going through the intermuscular plane, there is a single lead with two electrodes. There is a proximal sensing electrode, there is a distal sensing electrode. You can remember this diagram. The coil is here, there is a proximal sensing electrode here, there is a distal sensing electrode on the distal tip. What it does is it takes care of all the complications of long-term transvenous ICDs. If you consider transvenous ICDs over a period of 10 years, 5 out of 100 patients will develop an infection, and 1/4 of patients will develop a mechanical complication like a fracture. So 1 in 4 patients will not have a sustainable lead over a period of 10 years, and that's where subcutaneous ICDs come. Even when those mechanical complications develop and you try to extract, there will be acute complications during the surgery. There will be damage to the vascular access as well, limiting the reimplant. And in these cases only, it is the subcutaneous ICD comes. There is a lot of evidence currently which suggests non-inferiority of subcutaneous ICDs compared to transvenous ICDs in predominantly in primary prevention population. We talk about primary prevention because this is not inside the heart and it will not be able to pace. So it will be able to terminate a ventricular arrhythmia only by a shock. It will not be able to give anti-tachycardia pacing. However, it is associated with a not significant numerical lower risk of device-related complications. So there are trials which need to be remembered: effortless, Praetorian, and untouched. All of these have shown few concerns, but overall non-inferiority. The only concern initially with subcutaneous ICDs you should remember is an oversensing. It's an oversensing because it's in the subcutaneous pocket. It will catch local myopotential. So there is myopotential oversensing, and it will also is a little vulnerable for T-wave oversensing. But with improved algorithms, in the recent trials, untouched, which is the recent one in 2021, it has shown that the inappropriate shocks are less than what is encountered with transvenous ICDs as well. So these patients, so the indication we have, the indications stem from 2 guidelines, 2017 and 2022. In 2017 ACC HRS guidelines, they recommend if the patient has a criteria for an ICD with inadequate vascular access or at a high risk of infection, such as in dialysis, then and in whom there is no bradycardia or bradycardia pacing requirement. So I told you, subcutaneous ICD cannot pace; it is outside the heart. Or if there is need for there is no need for ATP termination for VT, and the patient does not need a pacing for a heart failure. So patient cannot be a candidate for CRT. Patient cannot be a candidate for bradycardia pacing. And if that patient has a vascular access issue or a high risk of infection, then only it's a class 1 recommendation for subcutaneous ICD. So there are class 2A recommendations also. It can be used as an alternative for a transvenous ICD, but that is a class 2A recommendation, provided again there is no bradycardia indication or CRT indication. It should not be used as in a patient who has an indication for pacing. So in short, class 1 recommendation for subcutaneous ICD is inadequate vascular access or high risk of infection plus no indication of pacing. But the 2022 ESC guidelines did not give a class 1 recommendation. They said only when there is no indication for pacing, it can be used as an alternative as a class 2A. So I'll run through this. So the scope based on this is for majority of primary prevention ICDs. It is an alternative in cases of lead malfunction, and it is ideal for patients who have a primary electrical problem, who do not need pacing, like a Brugada or a long QT syndrome. So channelopathies or structurally abnormal hearts, which are like these hypertrophic cardiomyopathy, which have a very low requirement for a pacing in the early stages. So the complications are similar to transvenous ICDs for the implant, like pocket infections or hematoma formations. Long-term complications are significantly less compared to transvenous ICDs. The limitations we discussed doesn't have pacing capabilities. Also, because it doesn't have pacing capability, it cannot give an ATP. So all shocks, all therapies will be painful. In addition, all shocks cannot be a low energy shock because the coil is not inside the heart. So all shocks at 80 joules compared to the 40 joules in transvenous ICDs. So it will be more painful as well. As we saw initially liable for T-wave oversensing or myopotential oversensing, now it has been curved with advanced algorithms. Recently, a subcutaneous ICD has also been combined with a leadless pacemaker from the same company, Boston, and it has been used as a MCRN system, which includes both the ability to give a shock, ATP, and a VVR pacing as well. So you can remember this name, subcutaneous ICD plus leadless pacemaker. It's called an MCRN system for Boston. With that, I'll stop. I'll apologize for taking such a long time. Thank you.
Thank you, Dr. Anindya, for exhaustive talk on subcutaneous ICD, leadless pacemaker, and conduction system pacing. And if there are any questions we can take.
I think Dr.
Yeah.
Anindya can answer these last two questions that are posted in the chat box. One question is, Dr. Anindya, can CSP be used as a bailout for CRT even when ventricular pacing is expected to be low? You can see in the chat box.
Okay, so 1 second, sir. Can CRT be used for bailout for CRT when ventricular pacing is expected to be low? When ventricular pacing is expected to be low, it is always a class 2B indication, so it may be considered. It can be considered, yes.
And what is a lot and hot CRT, just in brief?
Yes. So lot and hot CRT is basically both are doing functions of a CRT. So CRT, what it does, it causes physiological resynchronization. Who are the patients who benefit from that? Left bundle branch block. So we just discussed the level of the block in LBBB in most of the patients is proximal. So definitely we can use a His bundle lead. A His bundle lead will be able to correct left bundle branch block in 50% of almost 50% of patients, and a left bundle branch pacing will be able to correct that kind of an LBBB in 66% of patients. So in 2/3 of patients, His bundle or left bundle will be able to correct. So hot CRT or lot CRT, what it does is there is a lead in the His bundle, there is a lead in the left bundle plus a CS lead. So the full form of lot CRT or hot CRT is left bundle optimized CRT or His bundle optimized CRT. So there is a CS lead, there is a coronary sinus tributary lead in the posterolateral branch preferably, plus a lead in the His bundle or in the left bundle. I will show them.
That's nice. Yeah, that
picture. I think I'll show them. It will be better, sir.
That is nice. So one of them had asked the question whether CSP, CSP versus CRT. Why is it not a conduction system? Is not a class 1 indication. I had put that down in the answer. There are no randomized control trials till now. There are no randomized control trials to show superiority of conduction system over conventional CRT. Now, of course, studies are being conducted. Once we have that, maybe then we will talk about the class 1 indications. So lot and hot is what Dr. Anindya had described.
So this is like
yes, Dr. Ayush, you can.
This is like a lot CRT. Yeah. There is a defibrillator lead. If you remove the defibrillator, then there is a lead in the CS tributary. There is a lead in the left bundle, and obviously atrial lead will be required for AV synchrony. That becomes a lot or a hot CRT. And if you combine the defibrillator lead, it becomes a CRTD, hot or lot CRTD. So this is His bundle optimized or left bundle optimized CRTD. However, you can, for the same patient, you can achieve synchronization provided there is no peripheral block with a left bundle lead or His bundle lead alone also. So that becomes left bundle optimized or left ICD, not a CRTD. So if there is a CRT, it means there is a CS lead in situ.
So my question is that in this hot or lot ICD, you have boxes like that? The PGs.
that is little complicated, sir. So for our students, there are two kinds of ICD leads. There is a DF1 and there is DF4. Because this lead, in this case, it's a hot or lot ICD. This lead cannot pace. The shock lead, this coil lead will not be able to pace, because there are two outputs from this lead. One is for shock, one is for pace and sense. The pace and sense for this lead is not being utilized, and that function will be taken over by this lead. So if an ATP is required or the VT sensing is required, it will be through the conduction system lead. So there will be a specialized kind of pulse generator, which is called a DF1 pulse generator, which will take the help of the conduction system lead for pacing and sensing, and it will utilize only the shocking capability of this coil lead. So the specialized generator which is required for these kind of devices is a DF1 generator.
Yeah, that is good for the students to know, but unlikely that you will be asked or anything more into hot and not. Yeah. Anunay, you have anything to tell to the exam going students?
I think everything has been summarized very well. And as you have explained it earlier, that conduction system pacing has to be still not a class 1 recommendation. So every LVV railway dysfunction should ideally be offered CRT. And yeah, it's a bailout procedure. If you're not able to achieve a good QRS duration, you are not able to get a good vein, then you can consider CSP. And subcutaneous ICD, I think I've not done even a single in last 7-8 years, and very few patients are truly they need subcutaneous ICD. And the same is for leadless pacemaker. Very few, I think, out of 100 patients will need.
Yeah,
So
exam
truly
purpose.
indicate. Yeah.
For exam, Deep, can 1.5 prevention be asked from the first presentation in this session? The ICD indications.
बताइए उसके बारे में थोड़ी just tell them it's important for the students to know what is it.
If Dr. Sirish is with us. No, so 1.5 prevention is like in those patients where primary prevention you are not very convinced that your ICD is going to help. You can add certain riders and indicate the ICD in such patients. Like you can put the Holter and look for the number of VPCs or the NSVTs that are happening. Then you can check whether the EF is less than 30% or not. Then one rider is that if the patient is not having syncope but is having history of pre-syncope. So these are the patients where if you are doubtful as just putting as a primary prevention, if these riders are present, you can go ahead and put an ICD.
Yeah, so that's basically in patients who cannot afford or in situations resource limited setting that can be used. In addition to ejection fraction, use additional criteria like Dr. Ayush was mentioning about non-sustained VTs on Holter as a criteria to implant an ICD, not just ejection fraction.
Nice. So that was about 1.5 prevention. Good. Anyone has anything more to discuss here? All good then. Thank you again, all the speakers and all the moderators. We have had 200 plus attendees in this whole webinar. We will be looking forward to support from the Indian Heart Rhythm Society and to conduct this every month. And then we will be conducting the next schedule on February 9th. Thanks all students for attending it. I wish you all the best for your exams. And then I'm sure you will all do well. And then see you again on February 9th, Sunday.
All the best. Thank you.